بسم الله الرحمن الرحيم. إن شاء الله هنبدأ الآن السيجن الأولى من البريست سيرجري بعنوان Updates in Breast Cancer Surgery. Now we will start with Dr. B. Sarafati, consultant of plastic and reconstructive surgery, Gustave Roussy, France. He will give us a talk about the robotic assisted breast surgery, the future of breast surgery. This is a virtual talk by online communication. We will start now.
Hello everybody, my name is Dr. Benjamin Sarafati. I'm a plastic surgeon. I work in Gustave Roussy and I'm specialized in breast reconstruction and breast cancer surgery. I want to thank you for the invitation. It's a real honor to be here. I hope next time I will be with you. And today we'll speak about something I really like. Is the robotic nipple mastectomy, and I will tell you what are the evolutions since I start this kind of surgery in 2015. To think from the beginning, when you think about evolution, you want to improve the quality of life of the patient, and if you can also decrease the rate of complication, it could be a good idea. And one of the major evolution of the surgery was the new of the laparoscopic surgery. We know that with laparoscopic surgery, we have less infection, less pain, a shorter recovery. So the idea of the robotic surgery in the breast is to apply the principles of laparoscopic surgery in the breast. And for sure, you will speak with surgeon. We can do without a robot for sure. But robot is the evolution of the surgery. Robots are everywhere now in the OR. They are everywhere in our life. And you can't debate about this. Robotic and computer will be in the operating room and we have to deal with it. So the concept is to reduce the large scar we have for nipple sparing mastectomy. So most of the time is lateral or inframammary fold. And with the robot is to put the scar not on the breast, but under the arm, and to reduce the size of the scar around 5 centimeters, around 4 to 5 centimeters. When we start this surgery, we have no CE marking, so we have built a clinical study with only for nipple sparing mastectomy for sure. We include in the study 80 patients. We have a C-cup maximum. If the patient has a bigger breast, it's not relevant for the robot because we have to reduce the skin, so we put scar on the breast, so the robot is useless, and we do immediate breast reconstruction with implant. We exclude in the study the smoker, the previous radiation therapy, and the previous scar. What we want to prove for the robot? What is the advantage to use the robot? We want to prove with this study. The idea is for most important things is the aesthetic result. For the patient, having no scar at all on the breast change everything. Since I started this technique, I have people who are coming from all over the country. They have BRCA1 mutation since 10 years. They are afraid of the surgery because of the scar, but now with the scar not on the breast but under the arm, they are okay to do the surgery. We want to prove that we have less infection because we have no contact between the scar and the implant. So in case of wound descent, we have no risk of implant infection. And most important thing, and I think it is the most important advantage of the surgery, is the very low rate of skin necrosis. Why? Because we use insufflation. We don't put any retractor on the skin, so it's softer than the retractor, and we preserve all the subdermal plexus. We have no scar at all on the skin envelope. So I'm sure that's why we have a very low rate of skin necrosis. So what about the pre-op marking? As you will see, we try to first design where is the anterior axis line because we want to put the scar posterior to this anterior axillary line to be hidden by the arm. With the superior scar is 4 centimeters. Now you see it vertical, but it will be at the end, and now I'll do for all the patients a horizontal scar. And the lower one is 1 centimeter, and you will see it's very far from the lateral fold of the breast. We try to hide the scar under the bra to be sure that everything will be hidden by the arm and by the swimming suit if the patient goes to the beach. So now I will show you a short video about the surgery. So we infiltrate the breast with a saline serum and adrenaline, and we dissect and we separate the gland from the muscle with a scissor, okay, to create a space. We put a trocar, so we'll dock the robot with only 3 trocar, okay? We will only use 3 arms. There is a laser cross to centralize your work, and you have to track the skin like this. Here you can see the carbon insufflation. It will be around 10 millimeters of pressure, and you will create the space between the gland and the skin. And you can have beautiful image like this. And as you can see, the dissection is quite easy. Why? Because of the insufflation, and also because we have a 3 division inside the breast. We see very well where we will work. As you can see, the robot reproduces exactly the movement of the surgeon, and we see very well how to finish the dissection. So first, we finish the separation between the skin and the gland. And as you can see, with the adrenaline, there is quite no bleeding at all, except some perforator sometimes. After that, it's difficult to know exactly where are the limits of the breast. That's why we will need an assistant who will touch the skin, and the assistant will tell you when you will have to go straight to the pectoralis muscle. You can do a retro nipple dissection and the biopsy if you need. And now here you can see the dissection above the muscle. So we separate the gland from the muscle now. And also quite easy, not a lot of bleeding. And after that, when everything is released, you can remove the breast like this. And as I said, I put all the implant above the muscle without any mesh, and we just put the implant above the muscle under the skin. And after that, we'll just put a small stitch on the lateral part of the skin to avoid implant movement. And that's all. So the breast reconstruction part of the surgery is very, very, very fast. We cut the stitch and it's finished. At the end, the scar is between 3 centimeters to 4 centimeters maximum. Thank you very much. I have done 130 patients. We have 1 superficial burn on the first patient, 8 infection, and 1 skin necrosis. And this is the most important things. We have a very, very, very low rate of skin necrosis. We have 2 conversions in open surgery because of the massive bleeding, and other one because the gland was very, very, very fatty, so it was very difficult to manipulate the breast with a fatty tissue. But now as you will see, we use the robotic aspiration, and we have no conversion anymore. 7 hematoma, 3 capsular contracture, 2 malposition of the implant, and we are very, very happy with this. We have made satisfactory questionnaire after surgery, and you will see most of the patients are very satisfied or satisfied after surgery. Something very important, we have done also rescue before and after surgery, and you will see, and it's very important, about the physical well-being on the chest and the sexual well-being. There is no difference before and after surgery because the patient feels very well to have no scar on the breast. Just to show some results, this patient has a BRCA mutation. She wants bilateral mastectomy with the robot. We've done surgery. We have a rippling effect because all the implants are above the muscle. we do only prepectoral breast reconstruction. Why? Because we have the fat grafting, and we do the fat grafting after, and you'll see quite good results without any implant behind the muscle. Okay, after one session of fat grafting, you can make the rippling effect disappear. And the scar is here, far from the breast. We can do that also for bigger breasts. You will see, you can see, even if the breast is bigger, it's okay because you don't have a lot of ptosis, no excess of skin. Okay, we see the rippling effect here. After one session of fat grafting, everything is okay, and the scar is here. With a very small ptosis, some degree of ptosis, you can do that also because with a mastectomy, you will have a skin retraction. This is the first procedure, bilateral mastectomy and medial breast reconstruction. We see the contour of the implant, especially on the right side. But after one session on fat grafting, you can obtain quite good results. And you will see we have corrected the ptosis only with the mastectomy, not because of the robot, just because of the mastectomy. What we have changed since I started this surgery, and this is a short video I want to show you because a lot of things have changed and it's for the best. First, about the scar orientation. Now I put all the scar horizontally. Why? Because you will follow the tension line on the skin and the result will be much better. So now I put all the scar, not vertically, but horizontally. I use a gel point mini. It totally changed my life because it's very easy to use. You can do everything through only one scar. And you can see here, we insert the gel point like this. Okay. I think Dr. Tosca used another type of thing, but I'm very happy with that. It's something really used for rectum surgery, but it's work also on the breast. And what is good is here you can put 3 instruments. So you will have the camera, you will have the grasp or the scissor, and you can have an assistant who use a suction, okay, manual suction to remove the blood, to remove the water, and to remove the smoke. And this is very important. As you can see here, the manual suction is very useful on the lower part of the gel point mini during the surgery. And you can see here, we have no leak with that, and we are very happy with this. You can see here with the manual suction, you remove the smoke, and you can do the hemostasis and removing the blood. In case of massive bleeding, I don't use that for all the surgery. In case of massive bleeding, I have an articulated robotic aspiration. With that, we can wash, you can remove the blood, remove the water, and it's very important in case of very precise massive bleeding. No, we have no conversion anymore in open surgery. About ADM and meshes, as you know that as a plastic surgeon, we are used to use this kind of device because the pocket of the implant is the pocket of the mastectomy is very large, larger than the implant. So I try to fix all type of mesh to fix the implant on the muscle. So I use dermal meshes, I use resorbable meshes, and I try the different way of suture it. When you are not a general surgeon, it's quite difficult, okay, because you are not used to do laparoscopic notes, okay, but at the end it's working very well. So I use a tiger mesh. I use also Surgimend. This is bovine dermis. It's quite thick, quite difficult to manipulate, and the idea is to fix the implant on the muscle to avoid any movement, because you know that after the mastectomy, most of the time you have an excess of skin, and the mastectomy pocket is very large, larger than the implant. So as I said, I tried almost everything to fix it, and very important, at the end of surgery, to put the implant now, I use a Keller phenol. It is very, very useful. It's a pocket like this, okay, with hyaluronic acid. The implant is inside. It's like, it's like when you cook, and you just have to push, and at the end, the implant is in the pocket. Okay, very easy, easier than when you try to insert the implant on the with your finger when the scar is very far from the breast. But you can see with a Keller phenol, and I encourage you to use that. I tried also to wrap my implant directly with ADM, and as you will see, it is not the best idea I had, but I tried. As I said, I tried almost everything. So the implant is wrapped by the ADM. It's very difficult, and at the end, the implant is inside, but the ADM is outside. So it's not a very good idea. Now I don't use any ADM anymore. I put the implant directly above the muscle, and I do a quilting suture on the lateral part of the pocket to avoid implant movement.
Okay.
What is the future also of this surgery? And I think Dr. Park has a good experience of that. Is single port. Is not available yet in Europe, but I think it will be very, very useful to have 4 arms through only 1 scar. And I think he will speak about this during this congress. Can you reduce the scar? I'm not sure, because we need some space to remove the specimen, remove the mastectomy, and put an implant, and to put it doing something less than 4 centimeters. I think it will be impossible. And the time of the surgery, when I started the surgery, it took me around 7 hours for both breasts. Now all the surgery for one breast, including the breast reconstruction, is around 1 hour and a half. So it's very, very fast. Same problem about the money, and it is exactly what is our job. Our job in this congress, and surgeons who use the robot, is to prove that with this robotic surgery, we have a better satisfaction with the patient, we have less complication, and I'm sure, like urologic surgery and all the kind of surgery, we can find a way to find more money for this kind of surgery. Something I've done with Dr. Tosca when I was in Berlin with a single port. We tried to do a transumbilical single port mastectomy. Okay, it was quite fun. Okay, it's working on the cadaver. Now we have to try it on a real patient, and you will see you can have a good access to the breast and remove the gland from the umbilicus. This is a cadaver for sure, and I think it could be a good idea, especially for gynecomastia. So this is something we have to do now for real patient, but it's published and on Cadaver Study, and you can see it on PubMed. So for sure, we are just at the beginning of this kind of surgery. The very good news for us in Europe is now we have the CE marking for breast surgery, robotic breast surgery. So now today, we have the authorization to do robotic nipple mastectomy, but only for prophylactic surgery. We have to build another clinical study for cancer patients. It will take time for sure. We have to convince our colleague, but the best publicity we have is our patient, because trust me, the patients are very, very happy of this kind of surgery. And I'm very happy also to announce, and you will see Dr. Tosca, Dr. Lai, Dr. Park, and all of those specialists in breast surgery. The first masterclass in robotic breast surgery, it will be in June, and on 20 and 21 of June 2024. It will be Gustave Roussy, with 1 day of last surgery, 1 day of lecture. I hope I will see you there in France, in Paris. It's a beautiful city, and everybody wants to come to Paris, so you can join the fun and the science. And it will be in June 2020. So see you next year. Thanks again for the invitation. And if you have some question, I will be with you in a few seconds. Thank you very much. Bye.
Thank you, Dr. Sarfati. if there's any question for Dr. Sarfati, because he's.
Hello, everybody. You hear me?
Yes, yes, we hear you. You hear us?
Yeah, I'm sorry. Yeah, perfect. I'm sorry not to be with you because I'm in holiday with my family. So it's a bad day for me, but I can be with you with the technology. So it's good. Thanks for the invitation.
Thank you. Thank you for your nice and amazing presentation. What about the axilla? We didn't see any dissection to the axilla. If you want to do axilla or sentinel lymph node biopsy, you did it first from a separate incision, then you complete your technique?
No. Yeah. Yeah. Thanks for the question. So for the axilla, so what you have seen is patients with prophylactic surgery, so they don't have axillary dissection. But if you need to do axillary dissection, you just move the scar to the axilla, and you don't need a robot to do the lymph node biopsy or lymph node dissection because you have a 4 centimeter scar, so you can remove the lymph node by hand. You don't need a robot for that. So for cancer surgery, we move the scar up to the axilla.
Okay. Any question from the floor? Axilla. Dr. Maher?
First of all, thank you, Professor Sarfati, for joining us in this meeting, and we hope that you will join in the upcoming meetings and come to Egypt. And I have a question that maybe I asked you the same question in 2019 about the cost and the time of the procedure. Is there any update like in this issue?
Yeah, the extra cost of this surgery is depending on the country where you do that. When you do, it can move from 1,000 euros to 3,000–4,000 euros per surgery. It depends how you buy the robot, how you buy the instrument. So really, it depends on the country where you are. But there is a real huge advancement in this kind of surgery, is the endoscopic surgery. Now, and if you want to come in Paris next June, you will see that. We know that we can do exactly the same surgery with classical laparoscopic instruments. Everybody has that in the hospital, and we have the same scar and the same result. Maybe it's a little bit less comfortable for the surgeon, but with endoscopic surgery, without robot, you can do the same.
Any other questions, Guru? Any other questions?
Thank you, Dr. Sarfati. I have a question regarding the positioning of the silicone implant. Is there any conditions in which you put it directly under the skin without any muscle coverage or mesh coverage?
Thanks for the question. So now in my immediate breast reconstruction, even for delayed breast reconstruction, I put almost 99% of my implant above the muscle. I see any advantage to put it behind the muscle. Most of the time it's painful for the patient. The aesthetic result is not very good. And now we have the fat grafting. So the idea to cover the implant with the muscle, for me, is outdated if the patient has enough to do at least 2 sessions of fat grafting. So the contraindication for robotic surgery is not the size of the breast, because you can do all the size of breast with a robot. The contraindication is the contraindication of prepectoral breast reconstruction. So if the patient has enough to do at least 2 sessions of fat grafting, you can do robotic and prepectoral breast reconstruction. If she doesn't have enough fat, you do classical surgery, because putting I try to put the implant behind the muscle with a robot, but you have a problem of malposition of the implant.
Dr. Sarfati, thank you very much for the presentation. I just was to ask you about the work about the cadaveric dissection through the transumbilical route. Don't you think you are going to violate the inframammary fold? And what about, can you repair it properly?
I have to tell you the truth, I don't know. The problem is the single port is not available yet in France, so it's difficult to, but you know, This is research, so we tried if it's feasible. And I think when I did that, it was not difficult to fix at the end the primary fold with the stitches along 4 centimeters, because you don't violate all the primary fold, you just violate it to 4 centimeter scar. So I don't know yet, but we will see in real life. But it's a way of research. But I don't have the results.
Okay, thank you. Any more questions? Dr. Sharif has got another question.
Dr. Sarfati, I would like to ask you about putting a drain. Do you always put a drain in the pocket? And if you do, how long do you keep it for?
Thanks for the question. So I put a drain even without robotic mastectomy. In all mastectomy, I put a drain. If I put an implant behind in the pocket, so I put a drain and I remove it when you give less than 30 cc per 24 hours. So most of the time, it takes between 3 to 5 days.
Thank you very much.
Any more questions? I think, thank you. Would like to thank you very much, Dr. Sarfati, for the presentation. And we have no more questions, and see you soon, maybe in Egypt, in the next
Thank you very
meeting.
much. Thanks for the invitation. It's a
Thank
real
you
honor
very
to be with
much.
you. Thank you. Bye.
Thank you, Dr. Sarafati. And the next presentation is also virtual under the title, Should We Scalate Auxiliary Management After the Results of Monarchy Olympia A and next presentation will be by Professor Dr. Sharif Naguib, one of the eminent breast surgeons in Egypt, about the surgical management of non-mass enhancement. تفضل دكتور.
Good morning. I'm going to present a talk about non-mass enhancement and its importance to the surgeon. It's a little bit more towards radio diagnostic specialty, but nevertheless, it does cause a dilemma to the surgeon, and that's because nowadays we surgeons are faced with this definition of non-mass enhancement very often in MRIs. So by definition, non-mass enhancement is an area of increased contrast uptake on MRI that does not present the features or the definite edges of a mass. This is an example . We need to try and get a biopsy of this non-mass enhancement area, and because MRI-guided biopsy is not really widely available, especially in Egypt, and it is expensive, so other imaging modalities are needed for accurate preoperative assessment. This is an example of an MRI showing a non-mass enhancement that mainly in the outer quadrants, measuring 10 by 5 by 7 centimeters, extending from the retroareolar area to very close to the chest wall. In general, MRI may show either a single mass lesion like here, or a single non-mass-like lesion in here, and sometimes a combination of both mass and non-mass enhancement together. Now, are all non-mass enhancement necessarily malignant? Actually, not really. In this publication by Chaudhary in 2015, you will see that it is 75% of the time benign and 25% of the time either malignant or suspicious of malignancy. Now, what are the lesions that may appear in MRI like non-mass enhancement? The benign lesions are usually pseudoangiomatous stromal hyperplasia, or what we call PASH, apocrine metaplasia, or radiation effect on the breast. In 11% of the time, high-risk lesions will show as non-mass enhancement. These comprise atypical ductal hyperplasia, radial scar, flat epithelial atypia, and intraductal papilloma. I'm sure that all of us surgeons or clinical oncologists have received pathology reports saying that the lesion was one of these strange names. In 15% of the time, non-mass enhancement will be malignant, and this group comprises DCIS, invasive lobular carcinoma, and invasive duct carcinoma. Now, the radiological appearance of NMI, of non-mass enhancement, could be one of these types. There is a variety of distributions, like linear, focal, regional, segmental, multiple, or diffuse. And there is a variety of internal enhancement pattern, like homogeneous or heterogeneous, clumped, or clustered ring. Are there any appearances or signs on MRI suggesting malignancy? Actually, yes. There are some factors that point to malignancy, like segmental, linear, clumped, or clustered rings, and the positive predictive value of these appearances go up to 97%. Some other factors point to benign pathology, like symmetric or spoke wheel speculation or central lucency. In this publication by Cho et al., they confirmed that the same factors we already mentioned could point to malignancy, like heterogeneous linear enhancement, or segmental clumped enhancement, or focal clustered ring enhancement. As you see in the same publication, linear, segmental, clumped, and clustered appearance of non-mass enhancement have a specificity rate exceeding 87% up to 100%, and a positive predictive value for malignancy exceeding 97% up to 100%. This was also confirmed by Yang et al. In his publication 2017, where he states in his conclusion that segmental distribution and clustered enhancement are malignant predictors for breast enhancement pattern. Nevertheless, malignancy has to be confirmed before you venture into surgical excision. So we depend on the BI-RADS classification that is received or that is perceived by the radiodiagnostic department. So if you have a non-mass enhancement that is classified as BI-RADS 2 or 3, then only follow-up is required. But if the non-mass enhancement is classified as BI-RADS 4 or 5, as you can see, biopsy has to be undertaken using any radiological method that shows the non-mass enhancement, whether it is mammographic, ultrasonographic, or MRI if it is available. Now, what do we surgeons have to do when we receive this report stating non-mass enhancement? As you can see, in 75% of the case, the non-mass enhancement will be benign lesions like PASH, apocrine metaplasia, and radiation effect on the breast. And these lesions do not require surgical excision, but only radiological follow-up every 3 to 6 months. In 11% of the cases, these lesions will be high-risk lesions like typical ductal hyperplasia or radial scar, flat epithelial atypia, or intraductal papilloma. These diagnoses are received upon needle biopsy, And if we face them, then we have to undergo surgical excision because these lesions are associated with malignancy in 20 to 60% of the cases. And of course, if the needle biopsy finds a malignant lesion, and this occurs in 15% of the time, usually one of the following, DCIS, invasive duct, or invasive lobular carcinoma, then surgical excision with postoperative radiotherapy is required. Now, will the diagnosis of non-mass enhancement change our attitude as surgeons? Actually, yes. When we receive this diagnosis on the radiological report, we need to do a wider resection than normal, and the margins should be examined by frozen section, because it was found that resection margins were found positive in a high percentage of cases. So finally, our take-home message is that non-mass enhancement is an important MRI finding that doesn't mean necessarily that the lesion is malignant. It carries a risk of malignancy or pre-malignant potential in 25% of the cases. Core biopsy guided by the easiest imaging modality, whether mammography, ultrasound, or MRI, is mandatory before any interference or any management. And accordingly, the clinical management will depend on the pathology and the initial level of suspicion received after the core biopsy. If it is a benign lesion, then only imaging surveillance is required. But if it is a high-risk lesion, especially containing atypia, if it is a DCIS, if it is an invasive malignancy, then surgical excision with or without postoperative radiation will be required. And finally, we surgeons have to make sure that we do a wider resection than normal and a frozen section examination of resection margins, because there is a high possibility of positive margins with the presence of non-mass enhancement. And I thank you so much for your attention.
Thank you very much, Dr. Sharif, for your presentation. But actually, this is a perplexing matter when you find it everywhere. I don't know if I'm going to face a case of non-mass enhancement. This is going to say that I'm going to make a wider resection is not an easy job, because you don't know what's the extent of the resection we are going to do. In a case of non-mass enhancement, we ask for, after by MRI, we ask for a second look ultrasound, aiming at finding another lesion or a mass. If there is a mass, so we can biopsy it. If there is no mass and non-mass enhancement, the problem that our colleagues radiodiagnosis, they don't scrutinize the lesions, as you say, as by red 2, 3, 4, 5. The high suspicious non-mass enhancement lesions are not well illustrated, and we don't know actually, shall we excise them or don't excise them, and so we excise the benign with the malignant and with the high-risk lesions. And at the same time, the extent of the resection is going to be bigger. Sometimes you are going to excise a mass with 2 centimeters, and then you find with the non-mass enhancement, a total of 7 centimeters is going to change your whole surgical plan. What do you do in such conditions?
The main message I wanted to send is the following, that non-mass enhancement is not really an alarming lesion, because it's only malignant in 15% of the cases. So in 85% of the time, it will be benign. So surgeons don't have to panic when they see the term non-mass enhancement on MRI. Of course, if it shows on mammography as architectural distortion, for example, or if it shows on ultrasound, then a biopsy is easy. A needle biopsy or a core biopsy is done before surgery. But if it doesn't show on mammography or on ultrasound, then we have a dilemma. And you cannot even localize it easily because it only shows on MRI. So this is to urge radiodiagnostic colleagues to try and find a solution for this dilemma. They have to import probably the software for MRI to localize زي الستيريوتاكتيك بتاع الماموجرافي، ان يبقى في software في الMRI to localize this area exactly and to allow the surgeon to decide what to do with it after biopsy.
تمام. يعني هو احنا معترفين ان هي المشكله في اللوكاليزيشن. هو it alarms malignant condition in about 15%.
15% وhigh risk in 11%.
Which is significant also. We should take it in consideration. But the problem is still how to localize the non-mass enhancement area and for excision.
Very difficult. لو هي معاها mass.
So it is not an easy job. I think as you told us before, we need much effort from the radiologist to help us to localize this area of non-mass enhancement.
Exactly.
To take a biopsy. This is either by a surgeon for excision if they cannot do fine needle or core biopsy.
هي الميزه كمان ان هي most of the time when there is an associated mass بتبقى النون ماس انهانسمنت اتاتشد ليها او حواليها. فالريكومنديشن اللي عندنا هنا ان احنا ناخد wider margin than normal and make sure that the margins are examined by frozen section. انما if there is no mass then we have a problem.
We have more questions, Dr. Gamal and then Dr. Ahmed Latif. فين المايك يا جماعه؟ دكتور ياسر معاك؟ اوكي دكتور ياسر.
دكتور شريف، في حالات اللي هو نون ماس انهانسمنت انا يمين زي حضرتك، في الحالات اللي حضرتك قلت عليها في ماس مالجننت وانا بعتها تعمل MRI ولقيت نون ماس انهانسمنت حواليها والبيشنت ده هياخد نيو ادجفنت كيموثيرابي، يعني مش هعمل ابفرونت سيرجري واعمل وايد لوكال اكسجن، انا هخش اعمل يعني العيان هياخد نيو ادجفنت وانا هعمل. طب الماركينج بقى نفس المشكله، يعني انا دلوقتي عندي مالجننت ماس 2 سم وقال لي اراوند في نون ماس انهانسمنت، هل فعلا هيبقى اولا 15% بس الانسنس اوف مالجنسي في الحاله اللي زي ديت ولا اكتر؟ وهل لازم اعمل برضو ماركينج ليها ولا هعمل ماركينج للمالجننت ماس اللي موجوده والنون ماس انهانسمنت دي هعتمد بعد كده على الMRI بعد ما اخلص النيو ادجفنت كيموثيرابي؟
هي النون ماس انهانسمنت في معظم الاحوال لو هي مالجننت هتبقى DCIS، ولو انا هدي نيو ادجفنت DCIS does not respond to neo adjuvant، وبناء عليه if you do a post neoadjuvant MRI you will find the same lesion there as it was. ف DCIS does not respond. ف I don't need to mark it. هو نفس الاريا will be excised again. It will not respond to neoadjuvant most of the time. Most of the time. It is a problem.
يعني مش محتاج اعمل لها ماركينج في الحاله زي دي.
مش هتعمل لها ماركينج لسبب ان هو معظمها لو كان مالجننت هيبقى DCIS. فانت كده هتشيله لان هو it will not respond to neoadjuvant.
Thank you.
معلش for the sake of time we have virtual presentations. This issue is a hot issue. We'll postpone the questions to Dr. Sharif at the end of the session because we have other virtual session presentations. Okay, our next speaker is Dr. Bahadir Joglu from Turkey. He currently works at Marmara University School of Medicine. His presentation is going to be should we escalate axillary management after the results of the Monarchy, Olympia, and Exponder trials? Dr. Bahadir. Hi. Dr. Bahadir.
Hi everyone, this is Bahadir Joglu from Istanbul,
Good
Turkey.
afternoon.
Today I would like to talk about should we escalate axillary management after the results of the Monarchy, Olympia and our Exponder trials. As you know, before 2010, after sentinel lymph node biopsy turns out to be positive, we were just dissecting the axilla with the level 1 and 2 the axillary levels. But after the Z11 trial, and we abandoned doing axillary dissection when we have sentinel node positive lymph nodes up to 2. But after these Monarchy, Olympia, and our Exponder trials, do we need to look for if the axilla is having a larger, disease burden in spite of having sentinel node positivity in maximum 2 nodes? So what is the new paradigm in the new era of axillary management in breast cancer patients. So especially in hormone positive patients, in clinical node negative patient, when you do an upfront surgery, should we do a frozen section for sentinel lymph nodes? If it turns out to be 1 to 2 positive, then do we need to do further axillary dissection? Again, in the light of the new findings in the Natalie, Olympia, and Monarchy and the RxPonder trials. So in patients with HER2 positive and triple negative tumors, there's no need, because if the sentinel node is positive, then it is evident then you should go, whether it is 1 positive or 2 positive or 4 positive, you should go for chemotherapy and or anti-HER2 treatment and or immunotherapy in triple negative cancer patients. So, but for the hormone positive cancer patients, there are some new contemporary indications, such as in the genomic test, if it's as a high score, then in addition to endocrine treatment in these hormone positive tumors, we may add chemotherapy, or in the large tumor or heavy axillary disease, which is N2 disease, 4 or more nodes are involved, then CDK4/6 inhibitors can be used in these patients, because the studies show that there is an advantage for disease-free survival. And also for BRCA positive, BRCA1 or 2 positive patients, there are some indications for PARP inhibitors also in hormone positive cancer patients, in addition to triple negative cancer patients. So let's start with the RxPonder study. So this study included only hormone positive tumors with the HER2 negative tumors, of course. And in those premenopausal patients, when you look at the recurrence score, if there is a node positivity in sentinel node, regardless of the number of positive nodes and the risk score level, if it is not positive, chemotherapy is needed. Therefore, if in the sentinel node there is 1 positive node, there's no need to do dissection, because the patient already had the indication for chemotherapy. So for the postmenopausal patient, if the risk score is 26 or more, regardless of the number of positive nodes, again, chemotherapy is needed. So if there is 1 sentinel node positivity in the frozen section or in the permanent histopathology, there's no need to do for extra axillary dissection in order to find if there's an excessive number of lymph node metastases. But what if the node, the risk score is 25 and less, and there is 1 or 2 positive sentinel nodes? Therefore, is there any role for axillary dissection? So from those studies before, there are some extrapolated findings, like in NSAPP-B28 study. So they look for the 21 gene score, recurrence score for prognosis and prediction for the taxane addition after adjuvant chemotherapy plus endocrine treatment. And they found that even in the low recurrence score, if there's the difference between the ones who had 3 or less lymph node involvement versus 4 or more lymph node involvement, the 10-year disease-free survival difference, absolute difference, is 13%. 10-year distant metastasis-free survival, again 13%, and 10-year overall survival and 10-year disease-specific survival is 10%. So this is meaningful. So even in the low score, recurrence score, if the node number, involved node number is increased, then there is an additional 10 to 13% of absolute benefit in disease-free survival and overall survival by adding chemotherapy in these patients. So if you have sentinel lymph node 1 to 2 positive, and we know that there's additional benefit by giving chemotherapy in these patients when they upgraded to N2. So what is the actual N2 disease patients among those who had a sentinel 1 to 2 positive node? So that's the question. So let's come to another study, which is Monarchy study. So here, the Monarchy study also included patients with a hormone positive tumor. And here, the abemaciclib indications includes hormone positive tumors and those with the pathological N2 disease, and also those pathological N1 disease, plus if the patient is more than having a tumor more than 5 centimeters or grade 3 tumors. So at the end of this trial, the the results showed us that the 5-year invasive disease-free survival, the absolute gain is nearly 8%, and distant metastasis-free survival, again, 7%. But there's no overall survival difference between two groups. So this trial has an extended result, and it was shown that this benefit is independent from the Ki-67 level. So in this trial, they had two cohorts, as it was shown here. In the cohort 1, which has the largest component of the population, so either the patient has, as I told you, is N2, or those with N1 disease plus additional high risk factor, or those with the N1 disease plus Ki-67, which is over 20%. So they show that there's no benefit for over 65 years of age, or who has a tumor, grade 1 tumor, or the stage 2 tumor. So the compliance is also not satisfactory in this trial, because this CDK4/6 drugs doesn't mean that the patient started and finished it with that 100% of the time. No, in nearly 40% of the time, in those patients who were elderly or over 65, they stopped using it in this drug. So the benefit should be escalated, should be evaluated according to this, discontinuation of the drug as well. So the NATALY study also explored the role of CDK inhibitors. Here, the used drug is ribociclib, and again, hormone-positive cancer patients are included here. Either they are N0 or grade 3 or grade 2, or has a Ki-67 level over 20%. Or they included N1 disease, pathological N1 disease, and N2 diseases. So the extended NATALY study results also published recently, and they found that after 44 months of follow-up, the invasive disease-free survival, the absolute difference is nearly 5%. But there's, again, in this study, they didn't show any overall survival between study groups. So in this NATALY study, more to say here is that the cohort only had the 20% of stage 2 disease and 30% of the stage N0 disease, but the beneficiaries of this study is mostly are the stage 3 and not positive ones. So here in this study, as you can see, if the patient have a not positive, either it's more than 4 nodes or less than 4 nodes, it was shown that the patients have a benefit from using ribociclib. Again, this study also showed that the using ribociclib also has some drawbacks, like the patient had an hepatic toxicity of grade 3 and 4 in 8% of time, and non-compliance of treatments again in 20%. So it is similar to the abemaciclib treatment. But the FDA approved the ribociclib with an aromatase inhibitor and COPAC for early high-risk breast cancer, and would like to remind you that here, this as a CDK inhibitor, even the patient has a 1 sentinel node positive, then the indication is there to use ribociclib in these patients. For the PALLAS study, as I can show that there is no benefit in any of the subgroups, so this is a study which showed that using palbociclib has no benefit in patients, either those whether the patient has a lymph node involvement more than 4 nodes. So when coming to the Olympia study, this is a study included patients who have a pathogenic BRCA1 or BRCA2 mutations. They included triple-negative cancer patients and hormone-positive cancer patients. And the hormone-positive cancer patients, they only included the pathological N2 disease. Therefore, there might be a reason to do axillary dissection in patients who had a sentinel node positivity up to 2 nodes. So let's see if there is any possibility to do this in order to find if there is any indication for using olaparib in these patients. Because in this study, they show that the researchers found that the 3-year invasive disease-free survival, the absolute gain is nearly 9%. And again, the 3-year distant metastasis-free survival absolute gain is 7%. Again, there is no difference in overall survival in this study. So in this Olympia study, as you see, because I told you that there are two cohorts, although they also included triple negative cancer patients, but also they have the hormone positive patients. But in this multivariate analysis, they found that the only benefit was reached in triple negative cancer patients. Therefore, there's no significant benefit in hormone positive and HER2 negative cancer patients. Therefore, if you have a sentinel node positivity in BRCA1 or 2 mutated patients here, you don't need to do any further axillary dissection in order to find whether there's an N2 disease in these patients as well, because this study did not show any significant difference by using olaparib in these patients. So what is the probability of having actual N2 disease when they are presented with clinical node negative at admission? As you can see, I already excluded using CDK4/6 inhibitors because ribociclib has an indication in N1 disease, and also for olaparib is, as you can see, in the hormone positive cancer patients, there is no significant benefit. Therefore, the only indication may come up for responder where there is the postmenopausal patient if the risk score, recurrence score is less than 25. So as you can see, the study from Memorial Sloan Kettering Cancer Center, and they collected nearly 12,000 patients, and they show that in this patient group and hormone positive patient group, only 9% of the patients have a node positivity more than 4 nodes. So again, another study, two studies here. As you can see, if the ultrasound is negative from the beginning, then the likelihood of having a node 2 or node N2 or 3 disease is less than 3%. So another study from Memorial Sloan Kettering and from the UK, they also show that if the ultrasound is negative, the likelihood of having an N2 disease is less than 3%. And the total number, when you look at the overall, all the studies here, the high nodal burden in this UK study, if the tumor is T1, which is less than 2 centimeters, the likelihood of having a N2 disease is 2%, but when the tumor size is larger than 2 centimeters, the probability of having N2 disease in this patient group who had a negative ultrasound at admission is 6%. So 6% is much higher than the ones that were previously reported, but still is acceptable in the whole large cohort. So when you look back again to the ACOSOC Z11 trial, they randomized people, the patients into 2 groups. One group had a node dissection when they had up to 2 positive nodes, and the other group, they had an axillary dissection. When they look at the axillary dissection group, they found that only 70% of those patients had more than 3 positive lymph nodes. So the findings are very, very different, from 1% to up to 17%, as you can see. But it is normal to see these different, results because the patient groups are different. These are not homogeneous patient groups, so the tumor size and the axillary, preoperative axillary staging methodologies are different. So this study is from Fox Chase Cancer Center, Philadelphia. They found also, they did it especially for this new indication. And if the number of sentinel node positivity is 2, then they found that the upgrade rate to N2 in these patients is 25%. So as you can see, this is the highest percentage, that the number that we showed so far in those patients. But this is the patient who had 2 positive nodes. If the patient had 1 positive node, then the upgrade rate is 10%. So if it is 3 positivity in the sentinel nodes, which is an indication for an axillary dissection, and here they found that the upgrade rate is 50%. So another study from France, from Paris Institute Curie, they again did the similar study, and they found that upgrade rate to N2 in sentinel node 2 positive patients is similar to the previous one, which is 25 to 26%. So also they found that if the patient had a lobular cancer, then the risk is 2.3 times more higher. So this is an interesting finding. We are all, as I said, the studies are not homogeneous, they're heterogeneous. So when they made a separate analysis for this group, they found that the risk of upgrade is higher in lobular cancers. So in this study, what they found is if 2 nodes are harvested and both are involved, again, this is very interesting, the upgrade to node to pathological N2 stage is 41%. So, but in general, when considering the benefit of the CDK inhibitors, because it's not 100% effective, so in 1,000 axillary lymph nodes, there were 120 patients with node N2 disease, and in those patients, according to this 10% of absolute gain, an average less than 10%, but let's say 10%, is 4 recurrences to be prevented by using a CDK inhibitor. That means you need to do 1,000 axillary lymph nodes in order to prevent 4 recurrences. So when looking from one side, oh, that's too high to have 45% of upgrade in those sentinel node 2 positive patients. When we make an axillary dissection, in 40% of the time, the patient may have 4 more nodes involved. But at the end of the day, the advantage that the patient has is less than you expected. So this study is also a very recent study from Sanomac Trials Group. It's an interesting one because the aim is to show the benefit of doing an axillary dissection in this subgroup of patients in order to prevent the disease relapse. Again, those studies did not show any benefit for overall survival, but also axillary dissection is not without any harm. So this study showed us how much we give harm by doing an unnecessary axillary dissection in these patients. So number needed to diagnose is 8 in these patients. That means 8 patients needed to undergo an axillary lymph node dissection to identify 1 candidate for adjuvant abemaciclib. And number needed to treat 13. That means 13 patients need to be treated with abemaciclib to avoid 1 invasive disease-free survival event at 5 years. So overall, 104 patients would need to undergo axillary node dissection to avoid 1 invasive disease-free survival event at 5 years. So in another way, in 104 patients, 9 patients will develop severe or very severe impairment of physical arm function. 13 patients will develop clinical signs of lymphedema. Therefore, 17 patients will need lymphedema treatment to avoid 1 invasive disease-free survival event at 5 years if completing 2 years of adjuvant abemaciclib. That means 80% of the compliance should be considered when thinking about the result of these studies as well. So the conclusion. So nearly 1/4 of patients with sentinel node 2 positive upgrades to N2 disease. Number increases if the sample sentinel node number is low. In postmenopausal patients with risk score between 0 to 25, if axillary is N2, then the chemotherapy is indicated. And abemaciclib indications may necessitate axillary dissection for young patients with sentinel node 2 positives, T2, and grade 2 tumor in whom only 2 sentinel nodes are harvested, but nearly 104 patients are needed to be dissected to avoid 1 recurrence, but leading 14 patients to develop lymphedema. Since 1/5 of patients discontinue the agent, therefore unnecessary axillary dissection rate becomes more higher. So ribociclib has been recently granted an FDA approval for its use in this patient subgroup, and the indications include N1 patients. Therefore, there is no need to do axillary dissection if you only have 1 positive node in the sentinel node. So it is unnecessary to do axillary dissection. One additional reason not to do the axillary dissection for CDK inhibitors. And no indication for oliparib in hormone positive and HER2 negative cancer patients. Therefore, no further axillary dissection is needed. So what about the frozen section for sentinel node to do in which patients? So here, what I would suggest, only just considering the responder trial, excluding the CDK inhibitors, hormone-positive cancer patients may need frozen section if they're postmenopausal and less than 4 sentinel nodes are sampled, because we know that in up to 16 to 17% of patients may upgrade to N2 in where if they are postmenopausal and the risk recurrence score is less than 25, because they would have an N2 disease, they would require chemotherapy. Thank you very much for your attention.
Thank you, Professor Bahadir. Next lecture, inshallah, will be presented by Dr. Fiorita Polakeki. She's head of breast surgery clinic at Athens Medical Center, and she's going to talk about quality of life after axillary surgery, lymphedema, and beyond.
Good afternoon, ladies and gentlemen, dear colleagues. I would like to thank the organizing committee and especially Dr. Maher Hassan for inviting me to join you in this Baheda Foundation conference. I will discuss in the next 20 minutes about the quality of life after axillary surgery, the lymphedema, and beyond. I'm Dr. Fiorita Polakaki. I'm a breast cancer surgeon, and also I'm the Vice President of Europodon of the European Breast Cancer Coalition. I have no disclosures. So, how about health-related quality of life? It has actually 3 domains, 3 pillars: the physical, the psychological, and the social. When we discuss about the physical, we all know about our morbidity, pain, swelling, and all these aspects. When we discuss about the psychological, it's all about overall life satisfaction and the perception, how we feel about our health status. About the social part, it's the ability to take part in valued activities and don't change the life that we used to have before the diagnosis. When we discuss about the lymphedema and its comorbidities, we have to fully understand the condition that we are dealing with. And first of all, the definition of the lymphedema. It's the accumulation of lymphatic fluid which leads to chronic progressive swelling, typically in the arms or torso or neck, following damage to or removal of lymph nodes. The causes and risk factors are more or less known. It's all the cancer treatments, each one individually, and the combination even worse, the surgery and the radiation, some trauma, the infection, the physical disruption or compression of all the lymphatic channels, from tumor invasion or from some genetic predisposition. The symptoms and signs are well known: the swelling, discomfort, heaviness, and skin changes. But what is the impact of axillary surgery and or radiotherapy on quality of life? The physical consequences is the pain and the lymphedema with a reduced range of motion, arm symptoms, morbidity, infection, skin changes, some other sensation, and some fine motor dysfunction, which is very, very annoying most of the time, and it lasts longer. The psychological effect, you can understand the impact that it can have in a woman's life, the anxiety, the depression, sleep disturbances, body image issues, and sexual dysfunctions. The social implications can be also important because they can alter the clothing habits. They have an impact on daily activities, work, sports, relationships, and sometimes the combination of all the above may lead to social avoidance. If you want some numbers about the lymphedema, 0 to 56 of all breast cancer patients suffer from lymphedema at some point, or some arms, or report some symptoms consistent with lymphedema with or without clinical diagnosis. All these arm symptoms indicate a later stage of lymphedema, and all these changes sometimes cannot be detected by objective measures. They may exist months or even years before the actual swelling of the arm, and the symptom report may play an important role in detecting lymphedema and clinical practice. There are many studies about the lymphedema and all the other comorbidities that are connected to it. The IOVA study was the first and the biggest one. It includes more than 1,000 of women aged from 55 to 69 years. The mean time from breast cancer diagnosis to lymphedema survey was around 8 years, and it's important to see that the 8% of breast cancer survivors self-reported diagnosed lymphedema and 37% self-reported arm symptoms. Patients who were diagnosed with lymphedema or arm symptoms had lower physical and mental health-related quality of life compared with the no lymphedema arm symptoms. The effect sizes were mild to moderate, and the dose-response relation between number of arm symptoms and lower health-related quality of life. Another study is about the impact of lymphedema on this HRQL 10 years after breast cancer symptoms. Here, there were 244 patients with breast cancer-related lymphedema and the triple number without. All the patients with lymphedema had significantly poorer health-related quality of life than patients that did not. The age, BMI, and the lymphedema severity, which health was dominant, arm affection, had only minor impact. What was important was the long-term impairments, and you can surprisingly see that the diagnosis of lymphedema, rather than its clinical severity, drove the large impairments. And here in this table, you can see all the life scores and all the differences in most of the symptoms. And you can see that we're all clinically significant. What is worse? What impacts more, radiotherapy or surgery? I really don't know. The scientific society doesn't have an answer yet. But as long as the locoregional control, both therapies have excellent control. But actually, the lymphedema observed and treated significantly more often after full axillary lymph node dissection than after radiotherapy at every measured time point. The highest incidence was 1 year. The increase in arm circumference of at least 10% was also measured more frequently after axillary lymph node dissection if you compare it with radiotherapy. The shoulder mobility was more similar in the two treatment arms at both time points, and in the quality of life there was no statistical significant differences concerning the arm symptoms, the pain or body image at 1, 3, and 5 years after treatments. Statistically significant difference was found: more swelling of the arm and hand after axillary lymph node dissection, and more difficulties moving the arm were reported after axillary radiotherapy. So you realize that both treatments are no good for the arm and the lymphedema. Until 2023, there were many studies, but little evidence comparing the surgical lymph node biopsy versus no axillary intervention. It was only assumed, we didn't have evidence, that reduced axillary intervention leads to improved quality of life. There were only indirect level 1 evidence supporting this assumption. There were 3 studies, but didn't provide enough evidence for this. Until last year, when the ENSIMA study was published, this is a patient-reported outcomes study which randomized trials with persistent impact of axillary surgery on arm and breast symptoms in patients with early breast cancer. Between 2015 and 2019, more than 5,000 patients were recruited for the first randomization. And there were 3 arms: the patients with and without sentinel lymph node biopsy, and the patients that, from those that have positive axilla, those that had completed axillary lymph node dissection. There was a questionnaire that was asked from them, and the completion response remained high. More than 70% of these 5,000 women at all time points for the first randomization answered, and over a follow-up of 18 months after surgery, arm symptoms with significant difference and breast symptoms with a tendency were improved in de-escalating treatment arms, which is really important. Patients with no sentinel lymph node biopsy benefited regarding arm symptoms and function, while no relevant difference in other scales were found. The questionnaires was assessed at baseline before surgery and 1, 3, 6, 12, and 18 months after the final surgery. using the OTC health quality of life qualification and its breast cancer module. The higher scores indicate better functioning and global health status. The score differences were over 5 points, considered clinically meaningful. And here you can see all the patients and tumor characteristics concerning randomization, age, BMI, stage, lymph nodes removed, reconstruction, etc. In these graphs, you will see concern the arm mobility. The arm symptoms, the pain, the swelling in arm hand, mobility limitation were all significantly higher in the sentinel lymph node breast node biopsy group if you compare it with the no intervention in the axilla group. And here you see that the arm mobility was significantly more restricted, as we could imagine, in the completion axillary lymph node dissection arm between first and third month postoperatively. But you realize the alignment of the curve as the time passes. After 6 to 18 months, the two curves are aligned. It's very important the prospective surveillance in early identification and treatment. The regularity of the measurement may be variable depending who measures and where measures. The schedule is very important during the visits. It's either postoperative or they are random visits. 1 to 3 months seems a reasonable surveillance interval up to 1 year post-surgery. The diagnosis of lymphedema within the first 3 months after surgery or radiation is cautioned because there is always a risk of misclassifying some normal post-treatment swelling that we see most of the times. The patient education on early signs and symptoms of upper body mobility, in particular progression of severity of concerns, is important. And of course, some considerations for us, the clinicians, for the lymphedema is the avoidance of venipuncture, injection or blood pressure in the ipsilateral arm, and of course the use of compression sleeves for air travel are the most widely recognized risk-reducing behaviors. Clinicians should encourage at-risk and affected lymphedema patients to exercise. Resistance and aerobic exercise is safe, but patients with lymphedema should work with a trained lymphedema professional in order to learn how to exercise safely and not get traumatized. These are some typical and well-known exercises for our lymphedema that will actually help our patients. And now regarding the management of lymphedema, there are many strategies. The combined decongestive therapy remains the best option with manual lymphatic drainage in the beginning, gradient compression bandaging, therapeutic exercises, and of course appropriate skin care. The combined decongestive therapy addresses to lymph hypertrophy, high fibrosclerotic alteration of affected tissues, sepsis risk, and improving, of course, activities of daily living. The lymphedema has 4 stages and the management goes accordingly. In the stage 0 or subclinical lymphedema is not treated with combined decongestive therapy. It's focused on surveillance only, together with use of compression therapy garments and manual lymphatic drainage. When we have acquired lymphedema of stages 1 to 3, the CDT is more effective in early cases and less effective in advanced stage cases. Surgically, the lymphovenous anastomosis, there are many options for early and secondary breast cancer-related lymphedema, but all of these require a multidisciplinary team decision. As far as the clinical pain management is concerned, also here there must be multidisciplinary approach in order to monitor changes with treatment. If it goes well, if it goes better, if it goes worse, and also assess the response to medication in order to standardize the treatment. A new onset pain or increasing pain may have other etiologies, including tumor infiltration of the brachial plexus or a recurrence. The early assessment and intervention post-surgery is important, and of course, the range of motion of exercises plays an important role during and after the radiation treatment in order to enhance tissue extensibility and promote normal movement patterns. There are manual techniques such as myofascial release, who improve tissue extensibility and enhance mobility. There are many trials, ongoing trials and studies across the globe for future perspectives from Mayo Clinic, from MD Anderson, from University of Basel, from many other places in the world, and we are eagerly expect to see the result of these studies soon. Patient education and empowerment is really important, and the multidisciplinary approach, as I thought many times, is really critical in order to address the lymphedema issue. Educate the patients about potential side effects and self-care measures, and empower them. Empower patients to actively participate in their recovery process. And of course, the multidisciplinarity, collaboration between surgeons, oncologists, physical therapists, psychologists, and other healthcare professionals. There should be a holistic approach in order to address the diverse needs of patients. Here is the last NCCN guidelines version about the survivors of lymphedema, and here you can see all the principles of physical activity. It's really useful, and you can direct your patients there to see what type of motions they can do safely without having the risk to traumatize. Closing, I would like to get this take-home message for you. De-escalating axillary treatment remains and will be the only holy grail for improving the lymphedema health-related quality of life for breast cancer survivors. Doing less, we usually offer more to our patients and their health-related quality of life. Thank you very much.
Thank you. If there is any question for Dr. Fiorita.
Thank you very much, Dr. Fiorita.
Thank you very much. Can you see me and hear me?
Yes, I'd like to ask you about, do you treat differently a patient having operation and within the first 1 or 3 months after surgery, she developed edema? Do you treat it differently from other patients that you are going to follow up them?
Usually when a lymphedema occurs so early, there are less things we can do because actually we are so actively involved in the post-operative treatments. Usually at that time, it's also the radiotherapy in front and also there is slight post-operative pain. So in the first 3 to 6 months after the operation, we usually treat lymphedema more mildly. The physiotherapy is less intense. We don't have such a freedom to do all these movements and all these fasciomuscular releases that usually the physiotherapist can do. And I tell again, it's also the radiotherapy that occurs at that particular time of the treatment. After 6 months, 6 to 7 months, when lymphedema occurs, usually, thank God, we see less and less, and I'm sure you will agree with me that the less we de-escalated axillary treatment, we do less axillary surgery, so we actually see all the time less and less lymphedema cases. But when this occurs at a later stage, let's say after a year or so, there we can do more things. And of course, if all the things everything we do with physiotherapy and exercise fails and CBD, compression we can do anytime, during any time of the treatment, even a month after operation, we can do all these compression techniques. If everything fails, then we consult them for some surgical intervention.
Thank you very much. Another question? Mike?
Actually, these patients with chronic lymphedema have high liability to have skin infection, cellulitis, and lymphangitis, especially with streptococcal infection. What measures you suggest for prevention of these repeated infections?
They need to have a very good hygiene for skin. We usually ask them to use a very mild soap from the pharmacy with normal pH, not something that is bacteriostatic. We consult them to avoid the frequent use of betadine and other things like that, and other clinics like that. And we also ask them to moisturize their skin very well. It's critical for the health of the skin at these cases to have a very, very soft and very elastic skin. So we give them some products like Cyclalfat we have in Greece that moisturizes the skin very well, gives it elasticity, and avoids this cracking that sometimes causes infections. The other thing that we should take care of is when this patient has diabetes. This is a comorbidity that plays an important role along with the BMI in the acquirement of the lymphedema. Apart from this, when we already have an infection, then we consult the internist in order to give most of the times, intravenous antibiotics in order to try to minimize all the side effects and all the concerns from the infection at the site.
Okay, thank you, Dr. Fiorita, for your valuable participation in our conference. We hope to see you physically
Thank you very much for
next
inviting
year,
me.
inshallah.
I wish I were there with you. I hope I will be next year.
Thank you very much. We will move to the next speaker, Dr. Mariam Motibi, consultant breast surgery, Aga Khan University, Nairobi, Kenya. Okay, Dr. Mariam. Hello? Do you hear us, Dr. Mariam? No? Online. Dr. Mariam, you can start?
Yeah.
Okay.
Yes, I can hear you. Can you hear me?
Yes, we hear you. Okay.
All right. Okay. Thank you so much, everyone.
Yes,
and I'm sorry I wasn't able to be with you in person. As you know, October is usually our busiest month. But thank you for the opportunity to just talk briefly about breast cancer management in Africa and specifically in Kenya. I have no disclosures to make, but over the next few minutes, I'd like to talk to you briefly about the changing demographics, reflect briefly around cancer care delivery in Africa before narrowing down a little bit to what's happening in Kenya, perhaps presenting to the audience some priorities and direction that I think are prudent and some opportunities and strategies for collaboration. As we know, we are facing one of the highest growing burdens of cancer. We are seeing quite a number of new patients, but also quite a high mortality. And what we do see that I would say pertinent to most of us is our patients tend to be 10 to 15 years younger than their counterparts in the West. And despite advances in increasing awareness and engagement, we're still seeing that a majority of our patients across the continent are diagnosed with advanced disease, and the lack of background of conventional screening in most parts of Africa. And as we said, the appreciation is really around the high incidence to mortality rates, and we look at and then how does this maybe translate to breast cancer, and why are our patients not only getting diagnosed with advanced disease but not completing their care? And we see a constellation of factors: the fact that patients have to pay out of pocket in order for them to access care, the fact that in many settings women are less likely to have the financial power or sometimes support in order for them to make health, and there is the I would say I would say the role of unpaired caregiving that is, I would say, quite prominent for women in many parts of Africa. This is combined with, I would say, poor referral pathways and sometimes poor lack of awareness actually between healthcare providers, where we know that in many parts of sub-Saharan Africa, patients are sometimes seeing 4 to 6 healthcare providers before definitive diagnosis of their cancer is made. And this is also compounded by social cultural barriers such as stigma, all of which may translate into delays in diagnosis and ultimately resulting in poorer outcomes. As we can see, looking at just the expenditure for cancer care, looking at upper middle income countries versus lower middle income countries, you see that ladies in upper middle income countries are spending maybe about 30% of their annual household expenditure on cancer-related costs. And looking at lower middle income countries, you can see that this is almost 1.5 times the cost, which is really not surprising that many patients are actually dropping out of care either as a result of financial toxicity or catastrophic health expenditure. Even as we think about cancer care in our setting, whether it's North, West, East, or Central, or Southern Africa, we do need to think about value-based care, where we know, irrespective of where you are on the continent or globally, cancer care does tend to be expensive. And it's really the tension between how do we provide quality care at a cost that's not going to break the bank, and what are the ethics behind this. And I think it's really time to have that bigger reset around what are some of these strategies that we can apply, and what are some of the matrix that we can apply in these settings to ensure that we're optimizing not just the quality care, but the cost effectiveness of our care. And of course, there have been things like the WHO Best Buy, that is more at a policy level, trying to look at how can we best inform governments and policymakers in order to prioritize investment. Things like Choosing Wisely Africa that have tried to look at how do we avoid practices to avoid that would result in financial toxicity, and that can mitigate and that can at least help to reduce the burden of finances for patients. And then things like the NCCN harmonized guidelines that try to streamline care across different settings, irrespective of where you are, and really looking at, even with limited resources, how do we use best evidence to deliver optimal care. And it really doesn't matter where you are in Africa, and whether in a rural or urban setting. I think the fundamental question that many we get asked by patients is, can I keep my breast? So how are we doing in terms of being able to achieve that goal? We did a study with the African Organization for Research and Training in Cancer about 2019, and then really reviewed that a couple of years later, trying to look at the different regions of sub-Saharan Africa and trying to look at the different, whether it's Lusophone, Francophone, Anglophone, and different settings, trying to look at what is the understanding or appreciation of management breast cancers, whether it's access to tumor boards, access to treatments and diagnostics, and maybe looking at some of the prioritization in terms of the availability of breast cancer drugs. So we have seen, I think, a promising upsurge in the number of countries in sub-Saharan Africa that have embraced national cancer control plans. Now, you might think, why is this a big deal? It's because it's actually acknowledging that cancer is a problem. I think for the longest time, we've had this incredible tension between infectious diseases and cancer care, but now we are actually seeing, cancer having more deaths than HIV, TB, and malaria combined, which really means that we've done a great job in sort of getting a handle on infectious diseases, but looking at how do we then transport that to cancer care delivery. And so we've also seen an increase in the number of services such as radiotherapy, systemic therapies are now more available. We are seeing, even in the centers that were surveyed, an increasing appreciation of the multidisciplinary approach to care, and of course embedding that in guidelines. As a surgeon, we were happy to note that quite a number of patients who had the majority of patients who had locally advanced disease received their neoadjuvant chemotherapy, and axillary node dissection was performed in many of the institutions with, I would say, a reasonable amount of yield in terms of the lymph nodes. However, sentinel node biopsies have lagged behind, essentially due to, again, the isotope concerns around technetium and its safe delivery. However, we've also seen an expansion in the availability of iron-based, like Sienna strategies that have actually been used in public settings that are helping to improve access to some of these surgical techniques. However, looking at a systematic review done a couple of years ago, just looking at female breast cancer and their management, what we do notice is, as concern, is that I would say 60% of patients surveyed out of almost about 7,000 patients underwent surgical excision only as their primary treatment. There has been, of course, an increase in the number of breast conservation therapies, but then looking at, of course, the countries that had breast conservation had to go hand in hand with access to radiotherapy and radiotherapy services. Looking at Kenya, we have seen an increase in the number of both public and private facilities, with both, expansion of the workforce across different settings, whether it's medical oncology, clinical oncology, and with the decentralization of radiotherapy services to actually try to bring care closer to patients, along with the increase in specialized diagnostics, whether it's stereotactic biopsies or more sophisticated staging like PET scans, to actually improve the decision-making quality. In terms of surgical services, we have seen the continuum go from, we've been talking about de-escalation, and we've seen, the spectrum of care all the way from aggressive axillary surgery to sentinel node mastectomies, breast conservation, and more, I would say, sophisticated oncoplastic and reconstructive aspects. But I think the main challenge has been this fundamentally remains out of pocket for most patients, because payers are not likely to pay and are seeing this as a cosmetic thing. So that's really the onus on us around how to increase the awareness around this. And looking at the utility of some of these techniques, it's the same techniques, but being used more sometimes for really advanced disease in terms of tissue cover, as opposed chest wall cover, as opposed to reconstruction. And of course, we've seen an increase in delayed reconstructions. Initially, insurances didn't want to pay for a reconstruction because they said, in 2 years, it was a bit dark, but they said, why are we paying when you're not going to be here in 2 years? And so they've realized that, our patients are continuing to survive longer and are now actually getting an appreciation of the need to support these for the wellness of our patients. So we do know that in Africa we have the highest workforce deficits, but I think these have been more emphasized, especially around the surgical oncology workforce. And we do know that surgeons can potentially be a catalyst for change in the different regions. But how do we then develop these communities of practice, and how do we use them as drivers for research to actually answer questions pertinent to our setting? I think it's important to know that the majority of breast surgical work is done by general surgeons. So how do we equip the general surgeons so that we know that, mastectomy done in Cairo is exactly the same as in, Nairobi or in Tanzania or in Cape Town? And how do we ensure that we are homogenizing the knowledge of these teams? And so through the African Organization of Research and Training, in collaboration with local and regional bodies, whether oncology or surgical societies, we've been really working around trying to improve that multidisciplinary approach. For the longest time, you would get care based on who you would see. You saw the surgeon and you would be, in theater before you could blink, or sometimes you saw the oncologist and you would have your chemotherapy, and then they would come in with a complete pathological response and anticipate you doing a breast conservation, which is incredibly challenging. And so we're looking at how do we not only support the current workforce, but also mentor and support through the medical school and different regional organizations, the workforce and the medical students, and nurses and oncologists who are actually in training. In terms of expanding the workforce, we've also been supporting the collaboration between the West African College of Surgeons and Queen's University in developing a surgical oncology curriculum. And more recently, we're looking to have a breast-specific curriculum. The surgical oncology curriculum in West Africa is really looking more at breast, colorectal, common cancers, prostate, and cervical cancers. But I think there's a clear need to have systems-based advocacy where we need to think as surgeons, for instance, we've been pretty much in the ORs. How do we get out and how do we start to engage with the rest of the teams around key aspects? We've just had an excellent talk on lymphedema and survivorship. So those are part and embracing the quality of life aspects of care that are critical. Some of the ways we can do this is actually through strengthening our primary base around primary healthcare providers, because they are actually the link between the communities and the health systems. And also looking at the critical role of engaging survivors, both in our lived experience, and if also in terms of they're the ones that policymakers listen to, and they're critical in terms of reducing stigma and reduction, and also perhaps having their role in patient navigation and support. I think we've had excellent examples previously from the team at Baher in terms of their patient navigation program. And so looking at how do we expand some of these best practice examples of the continent to different settings in Africa. Again, one of the key pillars that I think has been lagging behind is really around the need for research. We know that any evidence that we've been, I would say, largely consumers from the West in terms of the guidelines, but looking at what is happening for our patients. We know anecdotally that some of the protocols that we have, our patients respond differently. How do we then look at what is our disease burden? How do our patients react to their care? And are we doing the right thing for our setting? However, we did notice that there was really a paucity of evidence-based guidelines that helped to drive policy in our setting. And we tried as Aortic in collaboration with King's College London to look at how are we doing in terms of cancer research. And so what we saw was that, and which is clearly an opportunity for us to expand, is that cancer research in Africa only formed about 8% of all African health research. And I think we looked at about 24,000 papers over a 4-year period, and over a 12-year period. And what we saw was the, I would say 5 North African countries contributed to about 67%, with the 49 Sub-Saharan African countries contributing about 14%, really underscoring the need for us to think about how do we expand that so that whether it's from Cape Town to Cairo, we do have a sense of what's happening on the continent. We also tried to look at what was the disease burden versus the level of investment in the research. And what we saw is things like hematological malignancies, breast cancers actually did show a commensurate, I would say, output, although still not adequate. But you can see high burden cancers, liver cancers, cervical, ovarian, prostate cancers are still really on the lower end of the spectrum, really underscoring a need for us to think about how do we increase that. And then we looked at what were the drivers. Egypt, of course, we're pleased to note, was at least, I would say, the highest producer of research. So we'd be keen to kind of see, what is your best practice? How are we doing? How could we collaborate? And we tried to look at who is actually driving the research. And what we noticed was that, especially for countries like Egypt, you see that the initiator, the reason that you're having perhaps more research is because it's in-country driven, meaning there is deliberate investment. Whereas, as for instance, you may notice that these are the top 10 countries in Africa, but you see quite a number of them actually have the agenda that's foreign driven, which sometimes is nice if you're in alignment, but sometimes it's not necessarily the priorities of what the country needs. And if we look at the research level, engagement in research across the different, whether it's Africa, Europe, Latin America, what we notice is that there isn't much difference, whether it's surgical research, whether it's palliative care, whether it's diagnostics, and that tells us something. It tells us that Africa is not necessarily driving its own agenda in terms of research priority. And one would say if our patients are getting diagnosed with advanced disease, one would expect to see an increase in research around, palliative or supportive care, or perhaps in quality of life. But we can see it really is following the global funding stream, which begs the question: how do we think about, or how do we encourage our policymakers to actively invest in, in increasing this? So through the African Organization for Research and Training, our goal has really been trying to think through how do we transform cancer control in Africa through education, research, and advocacy, and not just advocacy, that higher level advocacy. Some of the things that practice, we have a biennial meeting next year. It's in Tunisia, so you're all invited. But looking at how do we, again, customize care delivery, how do we homogenize that? And that is through the different education and training committees, research committees, but also looking at mapping the sites and strengths of the workforce in different settings. But also, as I said, that higher level advocacy that's essential to ensure that policymakers start to listen to us, but also the grassroots engagement through training our primary healthcare providers on common signs and symptoms of cancers, but also the referral pathways that exist in their different settings, and also through research advocacy where they're able to sit on IRB boards and actually ask relevant questions for patients in their communities. I think global oncology is becoming an emerging field, and I think there is an opportunity for us to think about how do we, as aortic, hair, all other critical stakeholders come together to have a solid African voice, and how do we develop that multidisciplinary support with pooled advocacy that really translates into real impact on the continent. Again, it's really to appreciate that Africa is not a country. Each country maybe has their unique needs, but how it's really building the framework where we're able to listen to and address needs in each of our different communities, and start to build in not just community participation, but engagement in the whole continuum, including preventive care, but also building solid databases and registries that will help to support care across different settings. So in summary, it was a whistle-stop tour. It's difficult to sort of get into the details in just 20 minutes, but I would say we do need to think about multidisciplinary approaches to system care and cancer and breast cancer care delivery. Universal access to care is really a crucial component that we need to start to engage with. I think we do need to leverage our other stakeholders and think about how do we have a pooled advocacy around non-communicable diseases. We do have an opportunity next year at the UN General Assembly with NCDs being on the front line for us to really push the entire continuum of care across throughout settings. And I think there is an opportunity to expand care at all levels, but it really, the bedrock of that is patient care and education initiatives, and looking to collaborative models that work and enhance South-to-South collaborations. I would just want to thank you all, the Bahia Breast Cancer Conference, Aortic, and my home institution, Aga Khan, for this opportunity, and to you, the audience, for your attention. I appreciate the question. Thank you.
Okay, thank you, Dr. Mariam, for giving us a detailed acknowledgement about the problems of cancer management in sub-Saharan Africa, especially focusing on breast cancer management. We hope to participate with us next year, inshallah, physically in Cairo, inshallah, next conference. Thank you, Dr. Mariam.
So sorry, I can't hear you so well.
Okay. Thank you, Dr. Mariam, for participating with us. Thank you.
Next speaker, Dr. Galal Ghali, is one of...
Sorry, I can't hear the question. Sorry.
Dr. Galal Ghali, his presentation about inflammatory breast disorder, recent updates.
Thanks, Dr. Mohammed, and thanks, Dr. Maher. Thanks for the organizing committee for giving me the opportunity today to give this topic. Today, I will talk about the inflammatory breast disorders. This is multiple diseases which may be written in a chapter in the text, and I will try today to give you just important point about these inflammatory breast diseases and what is the recent updates in it. To just enumerate these inflammatory breast diseases that we will talk about today, maybe breast cyst, fat necrosis, breast abscess, mammary duct ectasia, mastitis, whether periductal, lactational, idiopathic granulomatous lobular mastitis, and finally the inflammatory breast carcinoma because it may mimic the inflammatory breast diseases. First, the breast cyst. What's the meaning of cyst? Which means fluid-filled cavities formed when the lobules becomes distended from blockage. It can present with palpable mass in about 15% of cases, and 7% of all females will have one, usually in the perimenopausal age. Here is in a mammographic picture, the typical halo sign of the cyst. Clinically, it may be single or multiple, unilateral in one breast or bilateral. Clinically felt as well-defined smooth masses and may be tender. In the mammo, that's a typical halo sign, and ultrasound is the best modality which has pathognomonic feature as a homogeneous oval or round lesion, hypoechoic or anechoic. And ultrasound is the best modality because it can differentiate between the fluid and solid content. As mentioned, as here in the picture, the content are fluids, so it will be dark. How to manage? Once diagnosed, usually there is no further management and it usually self-resolve. However, in large and persistent symptomatic cyst, it may be aspirated, either freehand or ultrasound guided, just for aesthetic reasons or to reassure the patients. And if the content of this test is bloody fluid or the lump doesn't appear, so cytology should be sent because cancer may be suspected, as there is only 2% of cases may have carcinoma with a cyst, but usually this is as incidental or accidental finding with the cyst, but not related to the cyst itself. And when you talk about entity like fibroadenosis or fibrocystic disease of the breast, which means multiple small cysts with fibrosis or fibrotic areas, although it is a benign lesion, usually associated with tenderness, asymmetry, and can mask malignancy. Most of those patients treated with just analgesics. However, in cases with persistent cyclic mastalgia, may be treated with danazole, which is classified as an androgenic medication used in those cases to block the release of the hormones related to the severe breast engorgement and breast pain. Also may be used in cases like endometriosis. When we talk about second topic, fat necrosis, it is acute inflammatory response in the breast leading to ischemic necrosis of the fat lobules, and if persist, it can cause chronic fibrous change, which may develop solid irregular lump, usually caused by the trauma. So it is mentioned as traumatic fat necrosis, but it can occur only in 40% of cases, while the majority of cases, 60%, related to the previous surgical or radiological intervention. Clinically, the patient is asymptomatic, usually in a small lump, or feel as a lump. Less commonly, there is a skin dimpling, pain, nipple inversion, and by radiology, it is hyperechoic complex mass, like here in the ultrasound, with mural nodules. By mammography, there is more developed fibrotic lesions which mimic carcinoma and appear as calcified, irregular, speculated masses. For this reason, imaging is crucial because solid irregular lump in the breast which may be suspicious, we should do ultrasound and mammography. And sometimes core biopsy is important to rule out malignancy, and here is the histological picture which reveals the fat lobules. Treatment of this fat necrosis, it's a self-limiting disease. For small cases, just analgesics and reassurance. However, large lesions of fat necrosis may require surgery just for aesthetic reasons. The third topic will be the breast abscess, and as we all know, it is just a collection of pus within the breast lined with granulation tissue, usually developed secondary to acute mastitis, related to breastfeeding more commonly, or causes leading to injury to the breast, cracked nipple with the breastfeeding, nipple piercing, breast implant surgery, as it is foreign body, which may induce secondary infection, patients with diabetes or low immunity. Clinically, it appears as tender fluctuant erythematous mass with punctum that may discharge pus and associated with constitutional symptoms like fever, malaise, and lethargy. And when we talk about imaging, in case of doubt, it is abscess or not, with ultrasound, may use guided needle biopsy and aspiration. This may help in resolution of the abscess, and we can do culture and sensitivity to guide the antibiotic prescription. So treatment, ultrasound guided needle aspiration, usually for small breast abscesses less than 3 centimeters, analgesics, broad spectrum antibiotics until the culture and sensitivity appear. Larger abscesses needs incision and drainage with local anesthesia, especially those of periareolar and retroareolar abscesses because it is painful area, and general anesthesia for the complicated non-lactational abscess, especially those with mammary duct fistula that can be treated surgically with fistulectomy and antibiotics for cure. Mammary duct ectasia, one of the topics which included in the inflammatory breast disorders, and by definition, duct ectasia means dilatation and shortening of the major lactiferous ducts, usually occur in the perimenopausal age, and most females by the age of 70 will develop bilateral and slightly asymptomatic in about 40% of cases. Clinically, it appears as colored green-yellow nipple discharge, red tender nipple, nipple retraction, palpable mass. In the mammography, appear as dilated calcified ducts, as here in the mammographic picture. By ultrasound, it has features of dilated duct, tubular, anechoic lesions, which may contain tissue debris in the subareolar region. And if biopsied, it can reveal multiple plasma cells on the histology, which is often referred as plasma cell mastitis, and best managed conservatively. Periductal mastitis, another name is plasma cell mastitis or mastitis obliteranis, which from its name means obliteration of one of the mammary duct by thick viscid secretions. So the milk duct widened and its wall is thickened, and it is an inflammatory infection affecting the mammary duct with fibrous obliteration. Clinically occurs in the perimenopausal and postmenopausal women, manifested by nipple discharge, nipple retraction, or subareolar mass associated with pain, usually in or around the nipple, and feeling of illness. However, in the younger females, they may develop cellulitis or recurrent subareolar abscesses. As usual, the treatment will be analgesics, antibiotics, follow-up, and whether mammary duct ectasia or periductal mastitis are not risk factors and they are benign lesions. One of the most important topics in those inflammatory breast disorders is the mastitis. And mastitis means can occur with or without infection, typically through Staph aureus if it is with secondary to bacterial infection, but can occasionally occur without infection, named as granulomatous lobular mastitis. Healthy women have rare to be develop mastitis. However, female patients with poor immunity like diabetes, chronic illness, or any impaired immune system may be more susceptible for this mastitis and can be classified into lactational or non-lactational. Lactational mastitis caused by milk stasis, mostly during lactation, when bacteria comes from the baby's mouth, enters the milk, so nipple tract. And it presented in about 30% of the breastfeeding mothers during the first 3 months of lactation or during weaning. Maybe unilateral or bilateral, manifested by tenderness, swelling in duration over the area of infection, and constitutional symptoms of the infection. Non-lactational mastitis is less common, especially in cases with duct ectasia, as periductal mastitis that we mentioned before. The tobacco smoking can cause damage to the subaerial duct wall and may predispose to this bacterial infection. Treatment: simple analgesics, broad-spectrum antibiotics. The female should continue milk drainage or frequent breastfeeding. And if abscess is present, it must be drained by local anesthesia. And if the abscess near the surface of the skin, either by needle aspiration or less commonly by small incision. Cessation of lactation can be also done by using dopamine agonist, which can be considered in cases with persistent infection or multiple areas of infection. One of the most important topics of the mastitis is the idiopathic granulomatous lobular mastitis. This rare or debatable disease constitutes about 0.3% in USA and lower percent in Europe. It is a benign, chronic, confusing breast inflammation of unknown etiology, which poses significant challenge for cure and preventing recurrence. Commonly occur in the childbearing age women, especially within 5 years of last pregnancy, and also associated with breastfeeding. Clinically, as here mentioned in the pictures, breast masses, pain, subcutaneous collection may be felt, sinus or multiple sinuses formation, skinny changes in the form of erythema, edema, ulceration, which may occur in 66% of cases. Sometimes there is diffuse breast involvement in about 30% of cases, and upon resolution, as here in the last picture, there is a scarring and skin retraction. Even after cure, there is cosmetic problems with this granulomatous mastitis. When we try to diagnose this lesion, no specific pathognomonic mammogramic features, just parenchymal focal asymmetry, distortion are common features in the mammography, while ultrasound reveals heterogeneous irregular pockets in 80% of cases, which have pathognomonic finger-like projections, and these pockets may be communicating together with parenchymatous edema. MRI has no role in evaluation of this mastitis, and both clinical and radiological findings are non-specific. For this reason, core needle biopsy has sensitivity of 96% in diagnosis. And why we need core needle biopsy? For 2 reasons. First, it simulates cancer. So breast mass, nipple retraction, may be inflammatory breast carcinoma or mastitis. This is the first one. Second, to confirm it is granulomatous mastitis, not due to bacterial infection, because the management will differ. There is no consensus, which means no randomized trials on the efficacy of treatment modality up till now. Authors mentioned that observation by spontaneous resolution may occur in about 50% of cases, especially in those cases with a small unifocal lesion, those with mild symptoms, and this may happen within 2 years. Antibiotics has limited role in management and should be guided by culture and sensitivity only in cases with secondary infection. Systemic corticosteroids, dose and duration were various in literature, and we will mention. By high dose prednisolone, 30 milligram per day dose for 2 to 6 months is the most effective one, with remission rate between 66 and 72%. Recurrence rate can reach up to 50%, and despite its systemic side effect, it becomes the standard of care. Drainage and aspiration through abscess puncture or incision depending on size of the pockets. However, this aspiration may fail, usually due to the necrotic tissue, which makes the aspirate thick and hard to extract. Other treatment modalities for this granulomatous mastitis, like methotrexate, which is immunosuppressant, can modulate the inflammatory process, because one of the theories of this granulomatous mastitis, it is due to autoimmune or hypersensitivity reaction or inflammatory process. So it can be used maybe in patients who failed or don't tolerate the high dose of corticosteroids, or patients who receive corticosteroids but have relapse after 1 cycle or 2 cycles of these corticosteroids. The regimen mentioned in the literature varies. Authors mentioned 10 to 15, other papers mentioned from 7.5 to 25 milligram weekly for 2 to 6 months. Evidence of this approach is limited and based on few studies. Other immunosuppressive drugs like azathioprine. Rifampicin is a promising alternative. Paper published in 2017 about its efficacy by 300 milligram twice daily for 6 to 9 months. And when I reviewed the literature, there is paper from Mansoura University mentions this rifampicin, and they have good result with its use. Surgery as wide excision of the lesion based on the extent of the disease can be used in only individualized cases. However, there is a lot of problems with surgery because major or ugly scar after surgery, asymmetry happen after this resection, unsatisfactory aesthetic results, and the problem with breastfeeding. The last systematic review about comparison of the different treatment modalities, there is a systematic review done on 57 observational study and 2 randomized control trials. This trial or this systematic review include more than 3,000 cases of granulomatous mastitis and compare the study of the different modalities. Those studies reported 19 different treatment strategies comprising between observation, medical monotherapy, surgery, or combined modalities, medical treatment with or without surgery. They found that the overall recurrence can occur in about 88% of the cases, and the cure rate or remission rate across all treatment strategies just in 13%. The conclusion of this systematic review revealed that among the monotherapy, surgery had the highest remission rate, which has significant evidence. Combination therapy, steroids and surgery, antibiotics had the lowest cure rate, and the highest recurrent rate occurred when antibiotic and surgery. Most successful for preventing recurrence were observation, methotrexate, steroids, and surgery. Another systematic review published also this year in the European Journal of Breast Health. This systematic review done on 80 studies, and they included about 400 cases treated by intralesional corticosteroids in idiopathic granulomatous mastitis. They found that the use of these intralesional steroids directly into the lesion thereby can bypass the metabolic first pass effect of the oral steroids and reduce the systemic side effect of steroids. The dose precision generally depends on the size of the lesion. Duration range between 3 to 6 weeks. Complete response can occur in 91% with methylprednisolone and 90% with betamethasone, and both have similar efficacy. And when compared the oral steroid regimen with the intralesional, the oral steroid also showed 80% complete response prednisolone, 90% in methylprednisolone group. Single study used combined treatment, both oral steroids and intralesional steroids, which showed complete response in 80% of cases. So it has efficacy comparable to those with oral steroids, and they found that methotrexate have the highest complication rate, making this modality questionable. Comparison of recurrence after intralesional steroids versus oral steroids. Within the intralesional steroid group, the recurrence rate of single study, which is a randomized control trial done at 2022, used betamethasone. We found that the recurrence rate about 20%, and it is higher than studies using methylprednisolone, which is only recurrence rate in 3% of cases. The recurrence rate in the intralesional steroids, just 6%, combined group using oral and intralesional 13%, which is lower than those using oral only or surgery, which have higher recurrence rate reaching 25 or 26%. One possible explanation for this discrepancy could be because the intralesional steroids achieve persistently high therapeutic level of steroid concentration at the target area of the lesion compared to the oral steroids alone, which resulting in prolonged resolution. And when we find that there is higher recurrence rate in the surgery group, these have mainly attributed to the residual disease after surgery post-excision, which can be eliminated with the repeated use of intralesional steroids, which is less invasive. So intralesional steroids can correct the problems with surgery if there is any infection left after surgery. This is a scheme which used in one of the hospitals in Germany, in Essen. They mentioned that mastitis, first to do imaging. If there is mass of unclear dignity, core needle biopsy is essential. If it is abscess, as we mentioned before, drainage, culture, sensitivity, antibiotics. If there is mass, core needle biopsy. If it is cancer, so it will be treated as malignancy according to the stage. But if it is granulomatous mastitis, high dose prednisolone therapy, oral. In case of sufficient response, surgery and can be done as last option. Last topic, the inflammatory breast cancer, and I will just mention that it can mimic the inflammatory breast disorders, which is a rare type, grows fast, spread quickly, at highest mortality, and just mention that it has the same picture and same features of inflammatory breast disorders. Just 2 slides. Usually occur younger than 40, and for this reason, those patients who have inflammatory breast cancer miss the screening because usually occur before the age of screening. And despite it differs from other inflammatory breast cancers, it has the features of inflammation as swelling, warmth, purple color of the skin, dimpling, thickening of the breast skin, which may look like the orange peel. For this reason, it is pod orange, and it is T4 from the start. Very rare, there is a lump, and not all symptoms must be present. Here is the picture of the inflammatory breast cancer, which mimic the inflammatory breast disorders, which you mentioned before, and the lump usually don't form in this form of cancer. For this reason, it is hard to diagnose because no palpable masses in 2/3 of the cases. And these inflammatory breast cancer differ from the locally advanced breast cancers. It mimic, because mammography can miss more than 50% of those cases, and for this reason, biopsy is essential. Cases usually occur before the age of the screening, and it can be differential diagnosed with infection, mastitis, and other cancers like sarcoma or lymphoma. Thank you. Sorry for being late.
Thank you, Dr. Galal. Any question from the floor?
الحقيقه انا بشكر الدكتور جلال جدا على المحاضره دي. الحقيقه هو يمكن لسه راجع امبارح بالليل من العمره وما كانش قادر يعملها، بس بصراحه هو عملها على اعلى مستوى، فيها كل الديبيتبل بوينتس بتاعتنا. كنت حابب نعرض كل النقط اللي كلنا بنواجهها من الانفلاماتوري بريست ديس اوردرز اللي بناخد قرارات فيها منفرده. كنت عايز اشوف هل في جايد لاينز بتحكم التفاصيل كلها ولا لا. ويمكن انا عندي كومنت على نقطتين، وهو الاسبيريشن اوف بريست ابسس، مش الاوبن درينج اللي احنا كلنا متعودين عليه، ان هو الترا ساوند جايدد ثيرابيوتيك اسبيريشن، هو ده بقى الستاندرد زي ما انت كاتب. يمكن اخر حاجه في الاوبشن انت عرضته في الابسس السيرجري. النقطه الثانيه الانتراليجنال انجكشن اوف ستيرويدز في الجرانيولوماتس ماستايتس. كلنا عارفين السيستميك افكت بتاع الاورال ستيرويد، او فاحنا بالفعل في بهيه بدانا استادي على الانتراليجنال انجكشن والريزلتس بروميسنج جدا يعني. فلو في حد عنده برضو اكسبيرينس في عشان الجرانيولوماتس ماستايتس من اكتر الحاجات اللي بتعذبنا كلنا في التريتمنت، والمريض بيقعد فيري لونج جيرني. فيمكن الانتراليجنال انجكشن سترويدز انا انبسطت جدا على الميتا اناليسيس لسه منشوره السنه دي على الانتراليجنال انجكشن، واحنا بالفعل بدانا باي ويكلي بروتوكول وبنفولو الحالات الريسبونس ليها هايل جدا الانتراليجنال لوكال انجكشن اوف سترويد.
بعد اذنك thank you very much for the واضح ولا؟
thank you.
بص يعني طبعا انت عملت لنا جود ريزومي about the inflammatory breast lesions و I thank you for this, but بما ان البرزنتيشن is educational انا عايزه بس شويه تصحيحات لبعض النقط.
اتفضل.
يعني what did you include breast cysts in the inflammatory breast lesions? They should not be included. Breast cysts are not inflammatory breast lesions. These are occur in the late reproductive periods. These are a non-integrated evolution of the breast stroma and parenchyma, so they form cyst. لما تبقى inflamed ممكن تبقى inflammatory breast cyst. الحاجة الثانية برضو كومنت على الدكتكتيزيا. مش كل دكتكتيزيا there is shortening of the lactiferous ducts. انت كتير قوي بتشوف في الماموجرافيك فايندنجز بنلاقي في dilated ducts. انت يمكن الكلام ده تقصد بيه البيريدكتال ماستايتس. لما يكون في periductal inflammation and subsequent fibrosis, this might cause shortening of the duct. لكن many cases we find this is a disorder, it's not a disease. انت شوف في حاجه اسمها الاندي كلاسيفيكيشن بنعملها على benign breast lesion. This is a disorder, it's not a disease of the breast. It is occurs by aging. It can occur لما as a subsequent finding you find many dilated ducts without any shortening. اخر حاجه برضو عايز اقولها cessation of breastfeeding in breast abscess. انت دايما بتبقى usually adopt this policy. مش كل واحده بيجي لها بريست ابسس وبنعملها درينج بنوقف البريست فيدنج خالص. بيعتمد على كذا حاجه، واخد بالك؟ الانفلاماتوري بريست كونديشنز انت قلت لنا انفلاماتوري بريست كانسر حاططها في الديفرنشال دايجنوزس، لكن انت صلحت الكلام وقلت this is mimics ان انفلاماتوري ليجن. انا عايز اسالك سؤال في زي ما قال الدكتور ماهر في الانترا ليجنال انجكشن. ايه الاكسكلوجن كرايتيريا اللي بتعملوها؟ انت بتحقنوا؟ عايز اعرف الاكسكلوجن كرايتيريا انهي حالات، اللي هل حالات ساعات بيبقى فيه مايكرو ابسيسيس، بيبقى فيه حاجات كده، انهي حالات اللي بنختارها، سايز قد ايه؟ عايزين نعرف الكلام ده because this is a very good things. كان في كلام بيتقال على توبيكال كورتيكوستيرويدز في الجرانومس ماستايتس. الحقيقه احنا كل الحالات دي بنعالجها كلها بالظبط ايه بلاسيبو، كل اللي بيتقال ده بلاسيبو لغايه ما نري اشور البيشنت لغايه ما يحصل سبونتينيوس ريكفري فور ذس جرانومس ماستايتس. فكون الانتراليجنال دي هتحل لنا تبقى بصراحه انوفيشن يعني.
لا الحقيقه احنا في كل الحالات اللي فيها مايكرو ابسيس بنعمل اسبيريشن الاول، بنتاكد ان مفيش اي اكتيف انفكشن. بعد الكالتشر ما بتطلع نيجاتيف واولموست تقريبا كل الكالتشرز اللي بتتاخد بتطلع نو جروث، فساعتها بنقدر بعد كده نحقن الاستيرويدز. لو في اي اكتيف انفكشن او في سوبر امبوزد انفكشن بكتيريال انفكشن مش بنبدا الاستيرويد. ولما بيبقى البرزنتيشن بيور من غير اي كولكشن او سواء كلينيكالي او راديولوجيكالي بنبدا الريجمنت بتاع الانتراليجنال انجكشن والريزلتس فيري بروميسنج. بس احنا لسه في الاستادي لسه ان شاء الله تبقى تو بي بابلشد فيري سون. يمكن يعني دكتور محمد برضو معانا في الاستادي وعاملين كذا حاله. الريسبونس اللي شايفينه مبدئيا كانيشيال رائع جدا، ولكن زي ما حضرتك قلت الانكلوجن كرايتيريا اللي عن الحالات اللي ما عندهاش اكتيف انفكشن او سوبر امبوزد اكتيف بكتيريال انفكشن او كولكشن، واحنا بناسبيريت ونعمل ونويت فور ذا ريزلت اوف كلتشر الاول.
دكتور جلال انا بشكرك جدا، محاضره عظيمه جدا. انا بس الدكتكتيزيا حضرتك قلت ان هي كومبليتلي ميديكال، احنا ستيل بنعمل ميجور داكت اكسجن، فامتى نعمل سيرجيكال ريسكشن او ميجور داكت اكسجن يونيلاترال او بايلاترال في حالات الدكتكتيزيا؟
Thanks, Dr. Rahim, for this question. Mammary duct ectasia by itself, if it's just incidental finding in the imaging, like ultrasound, just mammary duct ectasia without symptoms, without frequent nipple discharge, so just observation and conservative management. But surgery as major duct excision, if there is frequent profuse nipple discharge, especially bloody nipple discharge, if the cytology revealed there is papillary or papillary lesion in the cytology evidence, or if the radiologically there is intraductal lesion, not just secretion, because ultrasound can differentiate whether by ultrasound these ducts contain secretion, which mentioned as inspissated secretions, or there is intraductal papillary growth. So if the imaging mentioned intraductal papillary growth, or cytology revealed there is tissue in the cytology, or clinically patient symptomatic with profuse nipple discharge. These are indications of surgery.
We go to the next speaker.
Next speaker, Dr. Amr Demiri, consultant and director of surgical oncology in National Cancer Institute, is going to talk about internal mammary lymphadenopathy in breast cancer, uniportal thoracoscopic approach.
Good afternoon. Thanks a lot, dear professors and colleagues. I am Amr Demiri, consultant of surgical oncology and oncothoracic surgery, National Cancer Institute. I'm going to talk about internal mammary lymphadenopathy in breast cancer, uniportal thoracoscopic approach. Internal mammary lymph node and axillary lymph nodes belong to be the first station lymph nodes of breast cancer lymphatic drainage. Internal mammary lymphatic vessel is one of the most important metastatic pathways of breast cancer. So determination of lymphatic spread of breast cancer is important in assessing prognosis and determining treatment approaches. A short review about the anatomy of internal mammary lymph nodes. The internal mammary nodes reside immediately near to the internal mammary artery and vein, either medial or lateral, parallel to the sternum, 1 to 2 centimeters lateral to the sternal edge. Collecting lymphatics passed through the intercostal muscle beside each perforating blood vessel to join the internal mammary lymphatic system. Here in this illustrative diagram, the nodes most frequently involved in breast cancer are located in the 2nd to 3rd intercostal spaces and to lesser extent in the 4th intercostal space. As we said before, 1 to 2 centimeter lateral to the sternal edge. Normal internal mammary nodes are very small and not visible on CT scans, while abnormal nodes can be seen on parasternal ultrasound, CT, and MRI. A size criterion of 5 millimeters on MRI or greater had a high sensitivity and specificity reaching more than 90% for predicting internal mammary node metastasis. Here in this breast MRI, we could notice left-sided, sizable, suspicious internal mammary node in close relation to the internal mammary vein. So what is the prevalence and what are the risk factors for internal mammary metastatic disease? Internal mammary nodal involvement has been shown to impact prognosis and is a component of the AJCC staging system. The presence of isolated internal mammary nodal positivity is far less common, reaching up to 17%, than concomitant both axillary and internal mammary nodal positivity up to 50%. Internal mammary nodal disease can impact overall clinical stage and correlate with patient outcome. This is in case of presence of involved internal mammary lymph node when there is no evidence of axillary disease. This will increase the clinical end stage from N0 to N2B. While in the presence of concomitant axillary and internal mammary nodal disease, this will increase the end staging from N1 or N2A to N3B. So internal mammary nodal disease have an impact on overall clinical staging and patient outcome. This is a large trial published in the Annals of Surgical Oncology about prognostic significance of tumor-positive internal mammary sentinel lymph nodes in breast cancer. It was a multi-center cohort study. It includes about 3,700 patients with breast cancer, injected radioactive tracer at either peritumoral or intratumoral locations. About 20% of these patients had ipsilateral internal mammary lymph node identified on preoperative lymphoscintigraphy. Of these 20%, operative retrieval of lymph nodes was completed in 80% of these patients. Only 130 patients, constituting for 3.5% of all patients, noted to have internal mammary nodal metastasis, and of them, 43 cases have internal mammary nodal metastasis in isolation and not in association with axillary nodal disease. The risk factors for having internal mammary nodal disease are any breast tumor with more than 4 positive axillary nodes, a medially located T2 tumor, medial tumor of any size with axillary nodal involvement, if the patient is younger than 35-year-old with a T3 tumor, or T2 tumor with associated positive axillary lymph nodes. A trial for development of a nomogram for predicting internal mammary sentinel nodal metastasis in breast cancer patients was published the last year in the European Journal of Surgical Oncology. Factors as tumor size, tumor location, lymphovascular invasion, and the number of positive axillary lymph nodes histological graded were included for nomogram calculation. And all these factors except grading had a significant relationship with internal mammary nodal metastasis on a multivariate analysis. So what about the role of surgery in internal mammary lymph nodal excision? Coming from the era of radical and the super radical mastectomy, dissection of the internal mammary lymph nodes was routinely undertaken. A positive internal mammary lymph node was regarded as a poor prognostic feature. But later on, subsequent trials confirmed no survival improvement with extended mastectomy. As here, this is a case of mastectomy with excision of internal mammary lymph nodes in the second and the third intercostal spaces. So later on, after this era, no follow-up or no biopsy were taken from the internal mammary lymph nodes. Also, the open surgical dissection or biopsy of internal mammary nodal chain have a significant surgical challenge due to the location of the internal mammary nodes itself. They are located lateral to the sternum in the intercostal space, just anterior to the pleural space. So surgical approach to retrieve these nodes can be difficult, unyielding, or risky. Also, it may require additional incisions in case of breast conservation or mastectomy with reconstruction, and this may be difficult for the patient herself. So these concerns pushed us to the thoracoscopic excision of the internal mammary lymphadenopathy. What is our rationale? There is some controversy with respect to internal mammary sentinel lymph node biopsy regarding the location of injection, mapping agents, lower retrieval rates associated with internal mammary sentinel lymph node biopsy compared with axillary sentinel lymph node, up to 70% regarding internal mammary sentinel versus 97% for the axillary sentinel lymph node. Also, in addition, it remains unclear whether radiotherapy to internal mammary lymph node region can improve survival in patients with positive internal mammary lymph nodes. Therefore, thoracoscopic internal mammary lymph node dissection was designed in many studies. What about our technique for thoracoscopic excision? First, the patient is situated in the left lateral decubitus under double lung ventilation. We do not need double lumen endotracheal tube as in thoracic conventional surgeries. We here need single lumen, and a single incision of 3 centimeters in the fourth intercostal space in the anterior axillary line is made. This is a patient who will mention later on post-right mastectomy. The skin incision is deepened through the fat, reaching down to the intercostal space to enter the pleural cavity. Then, when our camera was used, the first step to explore the whole pleural cavity to diagnose any additional malignant lesion. As we could see, we should explore the lung, the pleura, the diaphragm, the pericardium to detect any malignant deposition, any effusion, any suspicious lesion is present. In this case, she is a 50-year-old female post-mastectomy 3 years ago, and her PET scan shows right internal mammary lymph node with high SUV uptake. PET scan was done routinely for follow-up. This is during thoracoscopic exploration. This is the internal mammary vessels, internal mammary vein, internal mammary artery, and this is the internal mammary lymph nodes covered by the parietal pleura in close approximation with the internal mammary vessels in the second intercostal space. The section started by opening the parietal pleura over the nodes. There were actually 2 nodes present in this space. The section completed with removal of these nodes. The operative time for this technique was 45 minutes. Chest tube was inserted through the same working incision. We do not made any other incisions and removed after 12 hours. The patient was discharged at the same day, and the pathology confirmed that they were metastatic lymph nodes from her breast cancer. In internal mammary lymph node excision, thoracoscopic exploration has 2 advantages compared to open procedure, 2 specific advantages. The first one, the location of the internal mammary lymph node itself It can be placed exactly posterior to the costal cartilage. So in open approach from anterior, it may require segmental resection for the costal cartilage. Segmental costal cartilage resection is generally safe and not morbid procedure, but in breast cancer, these cartilages are commonly placed under a radiated field. So it can lead to post-operative chondritis or even local infection. The second advantage, which is more important than the first one, it allows accurate intrathoracic exploration. It allows a surgeon to verify the presence of not only massive carcinomatosis, but also the diagnosis of small pleural implants. The presence of widespread pleural tumor has worse prognosis in comparison to an isolated lymphatic relapse. And this may require later on systemic treatment, not only radiation therapy for the internal mammary lymph node region. And this is our second case, a 59-year-old female patient, post-mastectomy 5 years ago, and she had right significant internal mammary lymph node. On her thoracoscopic exploration, we could notice that there are widespread pleural metastases everywhere. So just random biopsies from these pleural deposits were taken, and later on the patient was referred for her medical systemic treatment. Beside the specific advantages, uniportal thoracoscope has general advantages like any other minimally invasive tool: reduced post-operative pain, reduced pulmonary dysfunction. It may reduce the duration of drainage, may be not needed, reduce the length of hospital stay, average 1 day, for older population or in patients with limited pulmonary function, fewer days in receiving adjuvant treatment in comparison to the open approach. To conclude, management of internal mammary lymphadenopathy metastases in operative breast cancer continues to be a controversial problem. Uniportal thoracoscopic excision of internal mammary lymph nodes is a novel technique that may provide more accurate staging for breast cancer patients. A change of stage based on internal mammary lymph node state may lead to a change of prognosis and thus modification of post-operative treatment strategy. Thoracoscopic internal mammary lymph node excision can be a choice for regional control of breast cancer relapse in selected cases. Additionally, it also allows a complete intrathoracic inspection where pleural tumor is widespread, but it remains unclear whether this procedure can lead to improved survival, so further studies with randomization and longer follow-up are needed for the establishment of a safe management plan. Thank you. او بالراديوثيرابي الون، لا ده لسه ما فيش كلام فيه واضح قوي. حته الاضافه اللي بيضيفها الثوركسكوب في الحاجات اللي هي زي ما انا عرضت الحالتين بوست ماستكتومي واندر فول اب بكذا سنه، فدي نقطه اساسيه ان يكون معانا كونفرماتوري باثولوجي. النقطه الثانيه بيكسكلود اذا كان في اني اذر انتراثوراسيك ميتاستاتيك ديبوزيتس، فالموضوع مش هيبقى جاست راديوثيرابي اونلي، لا هيبقى في اذر سيستميك تريتمنت معانا. لكن هو الون ديبندنج على الثوركسكوبيك ريسكشن الون، لا البيبرز اللي مكتوبه في الموضوع ده قليله قوي وكلها حاجات سبوراديك، مش معمول راندومايز ترايلز على حالات كبيره في البخصوص الاصلي.
هو السؤال لو كان البروسيجر ده دايجنوستيك، فانا بيتهيألي ان البات سي تي والنيدل بايوبسي كان جيف انف انفورميشن. بات سي تي ونيدل بايوبسي، ولو كان ثيرابيوتيك فاللي احنا عارفينه ان الراديو ثيرابي از very effective against internal mammary lymph nodes.
Regarding the needle biopsy, in most cases they refuse because of the small size of the lymph nodes and the close proximity to the internal mammary vessels. بيبقى في fear من البليدنج او الهيموريج او البلورال انجري اللي ممكن تحصل. فنقطه depending on بيت سكان فقط في التشخيص بعد كذا سنه بوست ماستكتومي دي لسه ستيل كويري. النيدل بايوبسي بتبقى ادكويت في الحالات اللي هي الكبيره، لكن معظمها فعلا بتبقى سب سنتيمتريك زي الحالات اللي انا عرضتها دي، فبتبقى غالبا ريفيوز. هم الحالتين دول فعلا ريفيوزد فور جايدد بايوبسي.
وانا عندي برضه another comment اللي انا عارفه anatomically speaking، عشان احنا في الاول كنا اتكلمنا على الريجن الافكتد في البريست اللي بتبعت للانترنال ميموري، فاللي احنا عارفينه anatomically ان الانترنال ميموري lymph nodes drain the deep part of the breast not the medial part of the breast. في misconception عند الناس ان الميديال quadrants هم اللي بيبعتوا الانترنال ميموري. This is not true. هي deep part of the breast هي اللي بتبعت الانترنال ميموري مش الميديال quadrant.
يمكن تاكيد لكلام حضرتك ده بيصعب موضوع السنتينل ليمف نود فور ذا انترنال ميموري اللي هي الاماكن اوف انجكشن سايت سواء بيري تيومرال او انترا تيومرال، وده باين في الترايل الكبيره اللي كان فيها 3700 مجرد نسبه قليله اللي خدت الابتيك، وحتى من النسبه اللي خدت الابتيك كان الريتريفال اللي طلعت بوزيتيف ليتر اون ميتاستاتيك كانوا قليلين. فده من الدروباكس بتاعت السنتينل ليمف نود.
والبيبر اللي حضرتك عرضتها ما حددتش السايتس اوف ذا تيومر في انهي حته في البريست
خالص،
انما 20% تقريبا هم اللي طلعوا internal memory positive، فغالبا ان 20% of the tumors were in the deep part of the breast.
و40 patient من ال 20% هم اللي كان عندهم isolated internal mammary lymph node.
شكرا.
هي بص يعني احنا واحنا نواب اوائل الثمانينات كان الدكتور مدحت خفاجي كان بيعملها روتين في كل الميديال كوادرانت ليجنز، وكان بيفتح ويرسكت جزء من الكارتريدج الثاني والثالث وياخد الليمف نود. قعد فتره كده سنه ولا اتنين وبعدين بطل، واحنا نسينا حتى موضوع الانترنال ميموري ليمف نود اكسجن او بايوبسي مع الادجفنت والنيو ادجفنت كيموثيرابي. فانا هل في حاجه انديكيشن واضح امتى نعمل اكسجن للانترنال ميموري ليمف نود؟
From the first shot يعني كاكزيلري ديسكشن مثلا مع الحالات لا لسه ما فيش حاجه واضحه. الاساس بتاعنا في الثوكاسكوب هو جاست هيبقى دايجنوستيك في هذه المرحله، ده الكلام الاساسي بتاعنا.
دايركت بايوبسي
بالظبط.
لا يعني هل هو ده بيبقى الاونلي ليجن اللي موجود في البيت سي تي بوزيتيف عشان كده بتخش تاخد بايوبسي علشان تتاكد؟
بالظبط، في الحالات بتاعتنا دي كان الاونلي ليجن اللي كان موجود فقط. زي ما بان فعلا البلورال ميتاسيس ما كانتش ظاهره في البيت سكان.
لا مش هيجيب السب سنتيمتر ده، هيجيب ما هو قال الليجنز كان سنتي او سنتي وشويه اللي انت عملته.
انا I have a comment طبعا. يعني لو دكتور عمرو احنا لو هنتكلم على التكنيك اتس جود تكنيك طبعا انت بتعمله you are doing with a thoracoscope rather than opening، لكن السؤال still are we need for doing such procedure؟ this is a question. واخد بال حضرتك ازاي؟ عشان بس برضه احنا ما نبقاش احنا حتى في الاجزله وي ار تراينج ان احنا نعمل سنتينل نود والسكه about كمان even omitting ان احنا نعمل سنتينل ليمف نود. فواي تو دو انا برضه زي ما بقول لحضرتك تكنيك از جود تكنيك I'm not talking about it، لكن why to do such long procedure حتى even it took about 45 minutes زي ما حضرتك تفضلت وقلت and at the end it will not give a benefit for the patient in his survival. Perhaps it may increase his morbidity.
هو يمكن الاجابه كلها في جمله ان الاجزله ليمف نودز اكزهوستد في الريسيرش، على عكس تماما الانترنال ميموري ليمفادينوباثي. المنطقه دي كونتروفيرشال ومش معروف لغايه دلوقتي المانجمنت بتاعها الايديال ايه. يعني حتى فكره الراديو ثيرابي مع عيان بوزيتيف انترنال ميموري ليمف نودز هل هيحسن من السرفايفل ولا لا؟ لسه فيها ديبيت كبير قوي. فالنقطه دي غامضه لغايه دلوقتي، ما فيش ستاندرد اوف كير للجراحه اللي احنا نقدر نعمل جراحه للانترنال ميموري. في بعض الترايلز بنحاول نقول في حالات معينه زي الميديالي لوكيتد تيومرز اللي في سايز معين، اللي بكذا اللي بكذا، ممكن نفكر نعمل، بس كل ده اندر ريسيرش. فالنقطه دي لسه ستيل غامضه بالنسبه لنا، كويري حته ان في ايديال مانجمنت للانترنال ميموري لينف نودز نعمل جراحه او لا، ده كويستشن، يعني كويستشن لسه اوف ريسيرش محدش يقدر يجاوب عليه. فيمكن الكلام اللي انا بقوله مش شرط اللي هو لازم يبقى بيتعمل، بنعرض حالات وبنطرق الباب، بس هل ده ينفع نعمله ولا ما ينفعش؟
ما عشان كده انا بشكر حضرتك على التكنيك از تكنيك سيرجيكال تكنيك، لكن انا عايز اقول ان ذا كونكلوجن يعني كان لازم
لا
يبقى هذا الامر واضح،
مش ستاندرد اوف كير. لا
تمام. شكرا.
دكتور ماهر اتفضل. مايك. دكتور ماهر اتفضل.
هو
عشان بس no conclude decision.
I think this is يعني my comment is this is a part of delayed relapse, nodal relapse, as we have seen the supraclav and the contralateral breast and the internal mammary. This is some sort of delayed nodal relapse of the breast. But my comment is, and there is a role of surgery now in removing this delayed nodal relapse, supraclavicular nodal relapse and contralateral axillary node and internal mammary. There is a role of salvage surgery for this.
Okay, Dr. Maher, last comment. Last comment. For time, for the sake of time.
شكرا دكتور عمرو على البرزنتيشن الهائله دي، ولكن بس كان السؤال يمكن طرح باكثر من لغه، يعني على الرول اوف ستيجنج في الحالات الديبيتبل زي ما كنا بنعرض امبارح الميدياستاينال ليمفادينوباثي اللي احنا بنبقى عندنا ديبيت فيها كتير ومش عارفين ناخد ديسيجن العيان ده ستاتيك اور نوت، وفيها الديبيت. فاحنا الاوبشنز المتاحه ايه اكتر غير الانترنال ميموري ليمف نود؟ نقدر نعمل الدايجنوستيك بايوبسي عشان اخد الستيج، يمكن مش كيوراتيف انتنت قد ما هو دايجنوستيك انتنت. فايه الاوبشنز الاكتر اللي ممكن نستخدمها في ثوراكوسكوب او ميدياستاينوسكوب علشان نشوف الميدياستاينال ليمف نود ادى بايوبسي في الحالات اللي فيها ريسك للانجري للميجور فيسلز او وات ايفر اللي تبقى ريفيوزد في الايمجنج انهم ياخدوا لها ايمجنج جايدد بايوبسي؟
هو اكوردنج للسايت اوف ليمف نودز، هي مش مساله مين اكتر من مين. يعني لو الميدياستاينال الريليشن للتراكيو برونكال تري زي البارا اورتيك او السب كراينال، بيبقى الرول الميدياستاينوسكوب هنا اكتر، وده حاجه يعني اقل انفيجن شويه من الثوراكوسكوب، لان انا ما بفتحش بلورا، ما بحطش فيه شيست تيوب، فده على حسب السايت بتاع الليمف نود هو ده اللي بيحكم. في الانترنال ميموري ليمفادينوباثي او في الانتيرو ميدياستاينال ليمف نودز عامه صعب ان انا اخد فيها بالميدياستاينوسكوب، لازم اعمل ثوراكوسكوب. فعلى حسب السايت هو ده اللي بيفرق معايا المينيمال انفيزيف ابروتش ازاي.
Okay, thank you. We'll conclude the session. Now we will take a coffee break for 15 minutes and we will come back to the session of oncoplastic breast surgery. Thank you, everybody.